Welcome to the conference of the Regions for Permit project. We are in Galicia, in the headquarters of the Galician Health Knowledge Agency in Santiago de Compostela. It's a pleasure to meet you, well, this time via streaming due to the COVID-19 situation. And well, it's with me Ana Cajaraville, that she is the project manager of the Regions for Permit project. And she will explain a bit, well, the technical things about how to ask questions during these 2 days of the conference.
Thank you, Jose. Good morning to all participants and speakers. And if you have any comment or question, just please send us to via Slido. And you will find the link in YouTube, on YouTube chat, and you can access to Slido via the web page or via the QR code. When you are in the Slido web page, just type the numeric code that you will find in the in the presentation during our conference. Thank you very much. Your time.
Yeah, thank you, Anna. Well, the conference is divided into 2 days. It will be 2 days with divided into 3 sessions, 3 thematic sessions. Well, first we will have a short introduction about how is the Galician health knowledge ecosystem, and also what is the policies of the Galician Health Ministry about the new strategy of personalized medicine. Well, as I mentioned, the session is divided into 3 sessions. The first day, today, we will have 2 sessions, that is research and innovation models to boost innovation and financial instruments to support innovation. During the second day, that it will be tomorrow, we will talk about how the public procurement of innovation process can help or can also foster the personalized medicine in our region and in Europe in general. But let me first to know a little bit about the project, to introduce and to give the floor to Gianni D'Enrico. I have to mention that the Regions for Permit project is led by the Toscana Life Science. And please, Gianni, I don't know if you can hear us. If you can give a short introduction about
I can hear you. I'm trying to share my screen, but it says that you are sharing your screen, so I can't right now.
Yeah.
So.
Well, yes, you can. I think you can share your screen, or maybe we can stop sharing our screen.
Yeah, because it doesn't give me the possibility right now.
No. Well, yes. Sorry, Gianni, if you think we are going to first show the introduction, the welcome of our managing director of ASIS, and then we will start with your presentation.
So, that's wonderful.
Antonio Fernandez Campa, he is the managing director of the Galician Health Knowledge Agency, the headquarters where we are now on live here, and is the agency that is in charge of innovation, research, and training of health professionals. Well, let's watch the introduction and the welcome of Antonio Fernández Campa.
Buenos días. Desde la Agencia Gallega de Conocimiento en Salud, desde ACIS, en colaboración con el Servicio Gallego de Salud, nos complace ser los anfitriones de esta conferencia dentro del proyecto Regions for Permit. Regions for Permit tiene un objetivo, que es crear un espacio de cooperación interregional en el ámbito de la medicina personalizada, alinear estrategias, alinear instrumentos financieros y áreas de inversión para lograr con todo ello una agenda regional europea que impulse la prestación de servicios basados en la medicina personalizada para nuestros pacientes. ACIS es una entidad pública del Servicio Gallego de Salud que fue creada para convertirse en el elemento nucleador del ecosistema de conocimiento y salud en Galicia. Para ello, colaboramos con los agentes del conocimiento, como son las universidades, la industria, con la sociedad en general, consiguiendo con ello una aplicación eficaz del modelo de la cuádruple hélice. Desde el Servicio Gallego de Salud queremos un sistema abierto a la nueva ciencia, a los avances del saber y a la tecnología y a la innovación. De esta forma, buscamos potenciar la medicina personalizada, tanto en la prevención como en la promoción de la salud, como en los diagnósticos y tratamientos. El reconocimiento de la Comisión Europea a Galicia como referente de la adopción de prácticas innovadoras para un envejecimiento activo y saludable, con 4 estrellas, la experiencia del Sergas en proyectos de compra pública innovadora para lograr nuevas terapias avanzadas y también la reciente implantación del modelo Living Lab en el complejo hospitalario de Ourense a través de la red Lab Saude, nos hablan como una región de referencia en proyectos innovadores y que apuesta por la medicina personalizada. Finalmente, agradecer a todos los ponentes su disponibilidad para participar en la conferencia y también, lógicamente, a todos los asistentes, muchas gracias por vuestra participación. Un saludo, bienvenidos virtualmente a Galicia.
Thank you very much, Antonio. Well, now, yes, it's the floor to Gianni D'Enrico that he will explain the objectives of the project and also the partnership.
Okay. Can you hear me? Can you see the presentation?
Yeah, you have to put in full screen.
Yeah, just a second.
Yes, well, it's full screen, not yet. Yes, perfect.
Okay. So good morning, everyone. My name is Gianni D'Enrico from Toscana Life Sciences Tuscan region, and I'm the project coordinator of Regions for PerMed. It's a great pleasure to be here and join this very interesting conference of another pillar of our project. So before we start, perhaps I will just give you a few words about why Regions for PerMed, why regions are important for personalized medicine, and in which phase we are of the project Regions for PerMed. So just to give you a overview, the local and regional communities have a key role in delivering the benefits of digital transformation to the public. In Europe, we have the regions, and local and regional communities are responsible for 50% of public investment. They receive and reinvest 25% of tax revenues, and they are the major public employer in all Europe. In Europe, there are about 74 regional assemblies and something like 280 regions and 80,000 local authorities. So this just gives us statistically how important are regions and the local communities here in Europe. So when we decided to implement and to build the Regions for PerMed, we were participating to focus groups, conferences, and workshops. And we saw that there was the scientific communities were involved, the industry was involved, and they were talking about implementation of personalized medicine in the healthcare systems. But in Europe, healthcare systems in certain countries are organized and managed by regional authorities. And even if they are not organized at the regional level, regions have important power in terms of investment and in terms of policies. So we understood that regions had to be involved. Regions have to be committed for the implementation of personalized medicine. This is what we did. We developed this project, which received funding from the European Commission and is part of the European pathway on personalized medicine, which is made by ICPermed, the International Consortium for Personalized Medicine, which is the main policy advisor of the European Commission, the ERA-PerMed, which is the financial arm, let's say, the funding arm of ICPermed, which is financing basic research and innovation on personalized medicine. And then we have Regions for PerMed, which started in 2019. Also, we are also part of SinoEU-PerMed, which takes care of international aspects, specifically with China. And this is the family of ICPermed. So these are all the what we call the family, the IC Procurement family. These are all the projects that have been financed by the European Commission with different goals, and which are now working all together to ease and fasten the implementation of personalized medicine. From this data, we can see that health research and innovation is already a priority in many regions in Europe. In fact, in 134 regional innovation smart specialization strategies, health innovation has been included as a priority. But when we go personalized medicine does not have a broader consensus. So few regions are investing on personalized medicine, and they are investing in uncoordinated manner. So like regions are moving according to their perspective, and they're not, at least this when we submitted the project, they were not communicating, they were not cooperating with each other. So when we set the Regions for Procurement goal, we wanted to coordinate European regional policy and innovation programs in personalized medicine. We wanted to align and strengthen the industrial specialization area in Europe and make personalized medicine an emerging industry, because the potential is huge. We want to enable interregional joint investment in personalized medicine and provide the European Commission, member states, and regional authorities guidelines to where to invest, and which are the key strategic area of personalized medicine at the regional level. Regions for Procurement specific objectives are to organize a technical dialogue, what we are doing today, around 5 strategic areas, provide a final action plan of areas of investment, establish a hub of European initiatives and partnerships on personalized medicine, and release guidelines to the regional authorities on how personalized medicine can boost local economies. These are the pillars, the key strategic areas that we have so far analyzed and on which we have delivered guidelines to the European Commission and member states. We had the first thematic area, strategic area, was big data, electronic health records, and healthcare governance. Then, and this was organized by Lombardy region. Then we went to Lower Silesia in Poland, and they organized health technologies and integrated care in personalized medicine. Then we moved to Saxony in Germany, where they organized how the industry can be better involved in personalized medicine. And now today we are starting the fourth key pillar on how to boost innovation in healthcare. This is the work of methodology, so you will better understand the purpose of this conference. So what we do at the beginning is to prepare a scientific rationale of the key strategic area we are tackling. Then we organize interregional conference and workshop with the stakeholders and the policymakers. We integrate the information that gets shared during these events with specific surveys, desk research, and then at the end we deliver a key ethic area report where we have policy recommendation, research and investment recommendation, and also a list of innovative models and best practices. So we have a conference, the workshop, the capacity building, and in-situ visits. And with all these, we will be able to gather all the information and deliver the right recommendations. So far, we had a KickOff conference in November 2018 in Milan during the European Alliance on Personalized Medicine Congress, which gathered over 500 participants, 30 countries, and the main European institutions were involved in our KickOff event. These are some numbers about the first key thematic area, and the first report, which was released in April. The health technology had over 130 participants for the conference and for the workshop, and 90 for the conference. The same numbers more or less for the Personalizing Health Industry conference. And today, here we are starting this new pillar of the project. We have also, besides the regions, we are also building the interregional committee, which gathers all the regions that are joining us and cooperating with us, adopting our policies. And we are also organizing a big event at the European Parliament for December 1st, and you will be updated as soon as the agenda has been finalized. Also, in terms of dialogue with the scientific community, we are taking an extra effort to deliver and submit scientific papers to make sure that what we release is scientifically sound. So these are the 4 publications that so far have been accepted by peer-reviewed journals. This is, lastly, this is our scientific community, our advisory board, which support us in when we build the scientific rationale and when we build the report. So, and I would like to once again thank all the members of our advisory board. That's it. So done. I'm really willing to, looking forward to this interesting presentation that we are having today and tomorrow. And in case of any questions, I will be here joining the discussions.
Thank you very much, Yanni. Well, it's a nice presentation to have an overview about the Regions for Permit project, how many things we were done until now, and the things that we're going to do in the future, the event in the European Parliament, and also the next thematic area that we will have after hours. So, well, let's continue. I will try to give a brief overview about the Galician health knowledge ecosystem and also the innovation strategy of the Galician Health Service. Well, I'm going to check if it works. Yes, I'm going to share the screen. Well, it's a first introduction about about Galicia, about the Galician Health Service, and also the health innovation strategy. Well, what about Galicia? Well, Galicia, it's a region that is in the northwest of Spain. Our population is about 2.7 million of inhabitants, and well, the people over 65 years old nowadays, it's more than 22% of the population. So, and it is expected that Galician will be one of the regions in the world with the highest ratio of centenaries per inhabitants. Also, we face another problem, that is that we have a very widespread population. In Galicia, with 2.7 million of inhabitants, we have more than 3,700 locations. So, as you can imagine, it makes difficulties in communication for the health services. Well, about the Galician healthcare system. Well, Xunta de Galicia, that is the government of Galicia. Spain is divided into autonomous communities. It's a decentralized system in Spain. So the government of Galicia is in charge also on the healthcare sector. The Public Health Authority, that is the Conselleria de Sanidade, that is the Galician Health Ministry, is divided into agencies and in also the Galician Health Service, that is the public health care provider. The Galician Health Knowledge Agency, that is ASIS, that is where we are now and where we work, it's the agency that is in charge of innovation, training for health professionals, research, and also technology assessment. Then we have another agencies or public foundations. It can be the foundations for the emergencies or others. Well, about the Galician Health Service, SERGAS. It's just a few figures about the Galician Health Service. As I mentioned, Galicia has almost 2.8 million of inhabitants. In Galicia, we have 14 hospitals, 500 primary care centers, 90 emergency centers, and we are about 36,000 healthcare professionals working in SERGAS. where 7,700 practitioners represent a part of the healthcare professionals. The budget of the Galician Health Service, well, we have to think that more than 40% of the total Galician public budget of the government of Galicia, it's dedicated to the Galician Health Service, more than 4,000 millions of euros in 2020. The Galician Health Service is divided into 7 health areas, 1 per main cities: Ferrol, Coruña, Santiago de Compostela, Pontevedra, Vigo, Lugo, and Orense. And also to give you a few figures about the Galician Health Service, in 1 year at Sergas, 25 millions of outpatient visits in primary care, 4 million outpatient visits also in hospitals, 174,000 surgery interventions, or 1 million visits, that is 2,750 daily emergency visits. Also, we are proud of our electronic health record, where we have more than 67 million of e-prescribed dispensations at pharmacies. The 3 main pillars of the Galician Health Service. Well, we have, as I mentioned before, one of the most powerful electronic health records systems in Europe. It's integrated that all the hospitals, also the primary care centers, and also the pharmacies can have access to Janus, that is our electronic health record system. Also, we are proud in the Galician Health Service that we are leading public procurement of innovation process, and also we are dealing with health innovation through dedicated teams. About ASIS, just a few words. Well, it was the public agency that it was created in 2016, that it was created to become the chief element of the health knowledge and innovation ecosystem in Galicia. As I mentioned before, it is divided into 4 units: research, training, technology assessment, and also innovation. But ASIS aims to be in the center of the biomedical research foundations, also on the health research institutes, also of course on the Galician Health Service, but also tries to connect all the agents that are in the network of the Galician health knowledge ecosystem, such as the business sector, the support agents, and so on. And now about the Galician innovation strategy. Well, as I mentioned before, well, we are a region where people over 65, it's one of the regions with the highest level of people over 65 years old. So, as you can imagine, our Galician healthcare system is focused on aging. We are participating actively in international networks, and the aging is on the top of the Galician priorities. That's why we are part of the EIP-ONAHA network, and in our RIS3, in concrete the Challenge 3, we aim to position Galicia as leading innovation region in the south of Europe for improving quality of life and healthier and safer eating by special attention to the elderly people. About reference sites, the network of the EIP-ONAHA. Well, we are proud that in the last call, that it was in 2019, we got the 4 stars EIP-ONAHA reference sites, that they award regions that they make a special attention to innovation policies and programs related to the aging population. We started with 2 stars in 2013, then 3 stars in 2016, and in the last call, that it was in 2019, we got finally the 4 stars, that is the maximum award that the European Commission through EIP-ONAHA network they have. And about the Galician Health Knowledge Agency, the part of innovation. Well, we are focused on 3 main pillars. The first pillar is about transfer and translation of research and development results. Also, we are focused on the open innovation, and also about the internationalization of the of our system, and also of the innovation that we are promoting. In the main part of ASIS, we aim to connect all the ecosystem that is part of how we call the health knowledge ecosystem. Well, as I mentioned before, we are part of Sergas that is the Galician health care provider, but we are also connected of the Galician Health Research Institutes and the public foundations. Also, we connect the business sector and support agencies. And about agents, so we have many agents that they are connected to ACIS, such as clusters, can be the health cluster of Galicia or the food cluster, also the life science business technology cluster, and others. Then also the government of Galicia, Xunta de Galicia, also is in charge of the economy and also to promote the innovation in general of the Galician economy. So the Galician Innovation Agency, GAIN, we are in touch with them, and also another agencies and parts of the government of Galicia can be IGAPE, that is the Galician Institute for Economic Promotion, and so on. Of course, in one of the pillars of the health knowledge ecosystem of Galicia are the three main universities that we have in Galicia. That it's in Santiago de Compostela, the University of Vigo, and also the University of Coruña. Then we are also connected with another agents, can be the Ministry of Science in Spain, and also the Ministry of Health also there. Well, and about the three main pillars that I mentioned before, well, the first main pillar is of the innovation and the research in Galicia is the transfer. What we aim is to transfer the research and development results to the market, and what we aim is to transfer in the scientific results generated in hospitals, in hospital laboratories through health research institutes and foundations that I mentioned before. Then about the open innovation, how we called? Well, about open innovation, we have three main activities. The first activity that we have is our health innovation platform. The health innovation platform that is led by ACIS seeks to support health professionals to foster and develop their innovative ideas. It is a platform that is open to channels, that is a platform that is an open channel to professionals, patients, caregivers, and companies. And it is composed by 7 innovation nodes, one per each care area, in charge of managing those ideas which are proposed by the professionals. Can be nurses, can be pharmacists, can be administrative staff as well, and so on. The other main activity that we have about open innovation and that we are very proud is the public procurement of innovation. Well, the first project that we have in Galicia, it was about public procurement of innovation, was in 2012. That is 2 projects that were running together, that it was Hospital 2050 and also Innova Saúde. It was a total budget of 90 million euros, where we had 33 PPI contracts and 1 PCP contract. It was the first PPI initiative implemented at the national level in the health sector. Then, based on the experience that we got thanks to the Hospital 2050 and Innova Saúde, we launched the Código 100 project, Code 100 project, that it was mainly focused on the aging population. With the Código 100 project, we aimed to turn Galicia into a region of reference in innovation in active aging, a region where it is possible to live with quality for 100 years and where the health system innovates to respond to the challenges posed by an aging society. The total budget of the Código 100 project was 13 million euros, and it was divided into 3 lines. the patient empowerment, that they were projects that they were aimed at strengthening the rights and the capacities of individuals, the line of new advanced therapies, that it was developments in the biotechnology and biomedical fields in order to increase the personalized medicine in the Galician health system, and also the last line was about professionals, that they were the initiatives to increase the skills of professionals, modernize the system, and promote an innovative culture among them. And we didn't stop after Code 100, about Código 100. Now we are running two new projects. One is InnovaTrial, that is an integrated IT system for the management of biomedical research and health sciences, science studies. And the other project that we launched last week, we had the open market consultation last week in the hospital of Coruña, that is Innova Microlab, that they are innovative solutions in the field of microbiology. And the last activity, I mentioned that there were three activities, the Health Innovation Platform and also the Public Procurement of Innovation. And now the last activity of how we call Open Innovation, it's the Galician Network of Health Living Labs, Lab Saúde. Well, we started in the hospital of Ourense because it was the best scenario, because the demographic characteristic of Ourense, that is a reflection of what will be the European population in the year 2050. And what is the Galician Network of Health Living Labs? It's an initiative which turns the Galician health service into real environments for testing innovative solutions. Here you can see some pictures of the new part of the hospital of Ourense, the post-radiography room and the double experimental room, or the multisensorial stimulator rooms, that it was a part of the new, of the hospital of Ourense, that it was built thanks to this program, PPI program, that I mentioned before, Hospital 2050 and Innova Saúde, that it was thanks to this PPI project that we built a new area in the hospital of Ourense that is dedicated for experimental for experimentation and of testing of new innovative solutions. The aim is to not stop in Ourense. The aim is to extend the Galician network of health delivery labs to the rest of the hospitals of Galicia and also the primary care centers. And the last part of the Galician health innovation strategy, it's about the internationalization. Well, our scope is mainly two parts. One is the European projects. Here you have well, some examples of running and already finalized European projects that we are running in the Galician Health Service and also in ASIS. One, it was Titan, that it was an Interreg Europe, Código Mais, that it was another Interreg Europe, but it was Galicia, North Portugal. Then the Empathics project, that it was a pre-commercial procurement project, that it was a Horizon 2020, and of course the Regions for Permit project, that is a CSA that we are running, and that the Toscana Life Science is leading the project. And the last thing about the networks, well, of course, our main network is the European Innovation Partnership on Active and Healthy Agent, where we were awarded, thanks to all the activities and the projects that were focused on the aging population with 4 stars. But also we are part of 2 networks. One is the IT Health Spain, that is the Spanish node of the IT Health. Well, where we have some projects also with them, and also Lab Saúde, the Galician network of Health Living Labs, is a member of the European Network of Living Labs, the ENOL, that is the International Federation of Benchmark Living Labs in Europe and worldwide. And that's all. That's well, a brief overview of Galicia and also of the Galician health knowledge innovation ecosystem. Now, I would like to give the floor, it's pre-recorded, but I would like to give the floor to Jorge Boal Viñas, that he is the General Director of the Health Assistance Department of the Galician Health Service. He will explain in his recording, well, all the developments and the future that we are going to do as regards the new strategy of personalized medicine in the Galician health service. Yeah.
Buenos días.
Yeah, we're going to put it.
Buenos días a todos. En primer lugar, me gustaría agradecer a la Agencia del Conocimiento en Salud, ACIS, la organización de este evento y el darme la oportunidad de presentar en este foro la estrategia de medicina personalizada de nuestra comunidad autónoma. El Servicio Gallego de Salud inició ya hace 2 décadas su camino en la incorporación de la medicina personalizada en sus procesos de atención a través de multitud de iniciativas de distinto tipo. En el ámbito de los sistemas de información ha sido referente dentro de España en la puesta en marcha de una historia clínica electrónica y un sistema de receta electrónico unidos y perfectamente integrados. Esto ha hecho que los cuidados y terapias se encuentren siempre adaptadas a toda la información disponible sobre el paciente, ya que en cualquier lugar de la comunidad autónoma al que éste acuda para recibir tratamiento, bien sea una consulta de atención primaria, una consulta hospitalaria, un bus de urgencia o incluso un vehículo de transporte de emergencias, durante su traslado al hospital, el personal asistencial dispone a un golpe de clic toda la información sobre sus pruebas de imagen, de laboratorio, patologías y medicación activa. El listado de medicación activa está asimismo accesible en cualquier oficina de farmacias, de forma que se pueda evitar las posibles interacciones de la medicación del paciente con cualquier otro compuesto de venta libre que desee adquirir. Esto, que en Galicia es una rutina y se asume como básico, es un primer paso hacia la personalización de la atención y que nos posibilita el seguir incorporando datos como puede ser los análisis genómicos que se vayan desarrollando a lo largo de la vida del paciente. En el ámbito de la medicina molecular, Galicia cuenta desde 1998 con la Fundación Pública Gallega de Medicina Genómica, referente a nivel europeo en su campo, que garantiza el acceso en condiciones de equidad, calidad, las pruebas genómicas que sean requeridas para el diagnóstico y tratamiento de múltiples dolencias, especialmente el diagnóstico prenatal, farmacogenética, enfermedades raras y cáncer de línea germinal. La Fundación es uno de los 5 centros de referencia del recién lanzado programa IMPACT sobre medicina genómica, coordinado para toda España por su director, el doctor Ángel Carracedo. El programa IMPACT pretende crear una estructura colaborativa para la implementación de la medicina genómica en coordinación con el Sistema Nacional de Salud de España, de forma que todos los pacientes puedan recibir con equidad y tiempos adecuados respuestas para todas las pruebas genómicas que sean precisas para mejorar su estado de salud, al mismo tiempo que se obtienen datos que podrán ser utilizados para la investigación. Esta red vendrá a realizar a nivel de toda España lo que la Fundación Pública Gallega de Medicina Genómica ya venía haciendo en Galicia, ofreciendo servicios de secuenciación genómica de alta complejidad, interpretación de los resultados y elaboración de informes clínicos para todo el Sistema Nacional de Salud en 3 áreas prioritariamente diferentes: diagnóstico de enfermedades raras, secuenciación genética en cáncer y búsqueda de biomarcadores para fármacos de alto impacto. Además, este programa se coordinará con iniciativas internacionales como el proyecto europeo 1 Million Genomes, el Consorcio Internacional de Investigación en Enfermedades Raras y el Consorcio Internacional de Genoma de Cáncer. En el ámbito de investigación, podríamos destacar iniciativas como la unidad mixta Roche-Chus, una iniciativa de la empresa Roche Pharma, sociedad anónima, y el Grupo de Investigación de Oncología Médica Translacional del Complejo Hospitalario de Santiago de Compostela. Esta unidad se centra en el desarrollo de soluciones innovadoras para mejorar el diagnóstico, tratamiento, evaluación y monitorización del cáncer, tanto de mama como de próstata, de manera individualizada, buscando resultados con aplicación clínica que mejoren las expectativas y calidad de vida de los pacientes a través de la oncología de precisión, centrándose en desarrollos de biopsia líquida y nanooncología. Y ya en el ámbito de terapias avanzadas, el Servicio Gallego de Salud está poniendo en marcha un centro de producción de terapias CAR-T académicas, que comenzará su próximo funcionamiento en fechas próximas, promoviendo un ensayo clínico mediante un acuerdo de colaboración con el Hospital Clínic de Barcelona, primer centro europeo que ha obtenido la autorización de uso de su propio CAR-T por parte de las autoridades reguladoras. Sin embargo, y a pesar de todas estas iniciativas ya en marcha, desde el Servicio Gallego de Salud hemos decidido dar un paso más allá y desarrollar una estrategia de medicina personalizada y terapias celulares para la comunidad autónoma, que sirva de hoja de ruta para todos los nuevos desarrollos y procesos que sin duda deberemos implementar en los próximos años. Esta estrategia se encuentra íntimamente relacionada con el Plan Oncológico de Galicia y la Estrategia Gallega de Enfermedades Raras, y se está desarrollando mediante una metodología colaborativa y la participación de los líderes de opinión de los servicios asistenciales implicados. Esta estrategia sentará las bases para la introducción ordenada, tanto en los programas asistenciales como en los de screening, de las herramientas de medicina personalizada ya refrendadas por evidencia científica, así como de farmacogenómica, mediante un mecanismo ágil de actualización de la cartera básica de servicios en base al nuevo conocimiento. De forma similar, ya en el ámbito de la medicina translacional, se diseñarán mecanismos que permitan programas de introducción temprana y de validación de nuevas soluciones, bien desarrollados por los propios investigadores de nuestros hospitales o bien de forma cooperativa con la industria biotecnológica, siempre guiados metodológicamente y evaluados internamente para poder garantizar la bondad de los datos y coste-efectividad de las soluciones, acortando el tiempo de desarrollo de las mismas. Se contemplarán también medidas de acceso a tecnología clave que permitan, por ejemplo, ir evaluando la madurez de la técnica como la proteonómica para su introducción progresiva en el laboratorio clínico. Medidas organizativas como programas de garantía de calidad y especialización de servicios en análisis complejos, organización de biobancos, etc. Todas estas medidas posicionarán a Galicia como una región líder en cuanto a la implementación de la medicina personalizada en los futuros años. Muchas gracias.
Thank you very much, Mr. Boal. Well, before starting the next part with the first session, I'm going to give the floor again to Anna, that she will explain how to ask questions and how to participate in the poll of the conference.
Thank you, Jose. During this conference, if you have any question or comment, just go to the Slido link that is on YouTube channel, on YouTube chat, sorry. And then if you want to ask some questions, you have the Q&A panel and also the polling session. So just type the code of the Slido in the Slido webpage, and you will access to both the Q&A section and the polling questions. Thank you so much. Jose.
Thank you, Anna. Well, we will start now the first session of the conference, that is research and innovation models to boost innovation. I'm going to give the floor to Dr. Gary Saunders. I think he's already here with us. Yes, I can see him on the camera. Well, I'm going to give first a short introduction about Dr. Gary Saunders. He's the Human Data Coordination from Helix's Hub, based at the Wellcome Genome Campus in the UK. Elixir is an intergovernmental organization that coordinates and develops life science research across Europe, making researchers easily find, analyze, and share data, exchange expertise and best practices. It is founded by the European Commission with the Research Infrastructure Programme of Horizon 2020, and Elixir consists of hubs and nodes. Elixir Hub coordinates the work done by the nodes. Dr. Saunders is responsible for ensuring that all data generated is compliant with the FAIR, that is, findable, accessible, interpretable, and resolvable data principles, among others, within the Global Alliance for Genomics and Health. Dr. Saunders, thank you very much for accepting our invitation, and the floor is yours.
Thank you, and good morning. Hopefully you can see my slides okay.
Yeah.
Excellent. Okay, so firstly, thank you to the organisers for the invitation to come along and speak to you. And it really promises to be an interesting meeting this morning. In my presentation, I will focus on the use of genomics data in personalised medicine across the EU member states. However, regions are clearly a critical consideration. The movement of health record-related data between jurisdictions, within and between countries, is often governed by the regions, and I look forward to the related discussions this morning. So yes, I'm Gary Saunders, the Human Data Coordinator based at the Elixir Hub, and I will be presenting on behalf of the Elixir Human Data communities, but also the EU member state-driven 1+ Million Genomes Initiative and the Beyond 1 Million Genomes project. So in this presentation, I will be discussing some activities that are helping us move towards cross-border access to beyond 1 million human genomes and the related healthcare data, and how these are applied to the personalised medicine programmes across the EU member states. So I'll firstly start with the technical solutions that we have, and then discuss the political landscape that we're working in and building for the future of personalised medicine. So there is no doubt right now we are in an era of genomics medicine. Data generation is no longer the rate limiting state, and many member states are embarking on national initiatives to generate genomic data and bring genomic healthcare data to all that need it. Historically, genomics data was generated for and by the research community, but it was often limited to the phenotypic data that was linked only for the purpose of a particular study. Now that the data generated at the whole genome sequence level and by healthcare systems means that the data is far richer, that the promise is there, that the associated healthcare data and possibly the link to other phenotypic data is possible, potentially often longitudinally as well. So this opens up huge opportunities for research and healthcare. And as genomics healthcare evolves and genomic research accelerates, these will feed into each other and result in benefits to both society and research. Genomics England is a good example. That has now sequenced over 100,000 participants and announced in 2018 that its 5-year plan to sequence 5 million genomes. As a use case example, rare diseases is one where this programme has made a huge impact. In the UK, there has been a diagnostic odyssey of children born in 2003 onward, bringing stories of personalised and earlier treatment and savings that range from reduced hospital appointments to clinical care itself. So many countries in Europe are proposing the use of the Recovery and Resilience Facility to fund sequencing at a national level. This facility has been set up to enable member states to prepare for a sustainable recovery from the coronavirus pandemic. However, despite increased scale of sequencing at a country level, one country, one region will not be able to achieve everything they want to alone. To maximise the opportunities for personalised medicine, we really need to work together. Increased value will come from access to cross-border data sets and access to a cross-border and cross-jurisdictional boundaries. And there are some very obvious examples of why we need to do this. So, rare diseases, by their nature, the problem of identifying others with similar phenotypes often takes a global search. Another example could be generating cohorts for each ethnicity within a country or within a jurisdictional region. So the question that I'm going to try and pose today is, how do we do this? So we need investment for infrastructure, and for that investment to be sustained. Infrastructure so often relies on project-based funding, but this really needs to change so that we're ready for whatever comes our way. The current pandemic is a good example to show that we need infrastructure to be in place, stable, and importantly, agile. Investments at a regional or project level then need to be coordinated for a system to work. The system we need to access data across jurisdictions, I would argue, needs to be a federated system. This is because the data that's generated by the healthcare systems in the regions is often a national or regional competence, and in so many cases cannot leave the jurisdiction in which it's generated. There also needs to be governance at the level of exchange interfaces, so that ultimately this infrastructure can be trusted, especially important or citizens won't agree to share their data. Interoperable, the setup can differ locally in different regions, but there needs to be essential requirements to ensure the interoperability of the wider system. And then also demonstrated, which feeds back into the trust elements. So how do we make this happen? So we need to bring together infrastructure components, including coordinated with the national roadmaps or regional roadmaps, to combine into a sustainable roadmap. The example I would use here is Elixir. This is a research infrastructure that connects national bioinformatics centres and EBI into a sustainable European-wide infrastructure for biological research data. And we can really move forward with this. So we may consider many different communities within the Elixir, but today I'm going to focus on only the human data activities, and specifically our mission to construct and operate sustainable infrastructure for human genomics and translational data in Europe to support life science research and its translation to medicine, and the associated vision to facilitate discoverability, access, sharing, and analysis of genomics data, including rare disease, linked to other data types at a scale of millions of participants. And then to demonstrate how use of this infrastructure can impact on genomics research and its translation into medicine. So this is quite a busy slide, and I will take you through it quite quickly. But it's to explain that Elixir has many components that help us to move towards our vision. So this slide shows just a snapshot of some of the key activities in this space and the Elixir human data communities that are striving towards our goal. And really, I want to describe that our focus is on coordinating the strategic investments in the services, projects, use cases, regions, and at a national level across Elixir toward a shared vision of a federated system of sensitive human data management. One further example is this paper that we published back in 2019. And this paper outlines how we can leverage European infrastructures to access genomics data across jurisdictions, and the minimum requirements that are needed, the federated environment, the use of existing infrastructures, and the need to build on an interoperable suite of standards. So this table in the paper outlines the main components that are needed for sensitive human data management at scale. So we have standards, application, programming interfaces or APIs, secure federated clouds, tools, workflow and services, an ELSI framework, a training framework, and a capacity building program. To go into a more technical level, this slide shows a very common workflow that leads through discoverability of data, data reception, storage and interfaces, data access and management tools, and then processing of data. The components here and the core services that are needed are being worked towards via many different projects, and Elixir coordinates or actively participates in these to identify the core services that are needed, develops these services and implements these services to provide a sustainable infrastructure for the management of sensitive human data at scale. And if we consider for the rare diseases use case, then we would use a service for discoverability of data at a regional, national and international level, federated EGA to store these data in different data places and different locations, Elixir authorization and authentication to identify ourselves, and then, for example, the RD Connect genome phenome analysis platform for the analysis of these data at scale. The fundamental underpinnings for much of the Elixir human genomics and translational data infrastructure are open, interoperable, and fit-for-purpose standards. And Elixir has formed a strategic partnership with an international standard setting agency called the Global Alliance for Genomics and Health to simplify the way that people search for and request access to potentially identifiable data in regional, national, and international genomic data resources. So working towards the GA4GH standards, APIs and toolkits that are used throughout the Elixir nodes, the GA4GH can use Elixir as a route into Europe. And ultimately, this is therefore a two-way partnership. Elixir nodes are able to feed their requirements directly to the GA4GH leadership, and GA4GH is able to utilize the coverage and the connectivity of Elixir to promote and support the implementation of its products in national and regional infrastructure used at the interface of genomics, research and medicine. And so if we look again at the infrastructure components that Elixir is coordinating, this time I've mapped on the GA4GH product to take us through the necessary steps. One example of implementation I've used here is Elixir Finland, where the raw sensitive human genomics and related healthcare data at the national level is connected from hospitals, labs, biobanks and projects. And then this is gathered, and some of this will stay at the site of the CSC, which is this service here. And Elixir Finland has been building a proof of concept demonstrator with Elixir Cloud and AI to run a federated variant calling pipeline across Elixir nodes in different jurisdictions. So this takes us across EU member states of Finland, Greece, Switzerland, but it could quite easily be different regions within one country or different regions within a number of different countries. So we're now positioning this infrastructure for the rare diseases use case for the EC member state driven 1+ million genomes initiative, and I'll come back to that later. And so the previous slide was an example from Elixir Finland, but the overall objective for Elixir, human data, is to implement this suite of products underpinned by GA4GH standards at the country and or regional level. So the technical components I hope to have shown are all very possible now, but I would now like to move into the political sphere and talk about the political will, because this political will is absolutely necessary to generate this federated system of human data management for cross-jurisdictional access to data. The countries and regions across the EU and across the globe need to come together to define how this will work and drive the effort forward. And this needs to be under an organised framework. Currently that's being driven by the 1+ million genomes initiative, the commitment of 24 countries in Europe to access genomics data across jurisdictions. So related to this, Elixir is coordinating the Beyond 1 Million Genomes project. This is a CSA that is a 3-year project started in June 2020 and brings together 29 partners. And Elixir is driving the 1+ million genomes roadmap and the commitment of 24 countries through the Beyond 1 Million Genomes project to give cross-jurisdictional access to 1 million sequenced genomes by 2022. The project, being a coordination and support action, aims to create legal guidance, best practices and recommendations to create a required infrastructure to get to the first goal of the initiative by 2022, and also ask questions of the long-term sustainability of the framework. So this slide shows on the left the 1+ million genome roadmap and how the project aligns to what is shown on the right. So it aims to, in the first year, define the requirements from all stakeholders for border access to genomics and personalised medicine data. In the second year, translate requirements from data quality, standards, technical infrastructure, and ELSI specifications into technical specifications and implementation guidelines that capture European best practice. And in the third year, beyond that, we also need to consider how the infrastructure will be adopted and how it will be operated in the long term at the local, regional, and national and European levels. We do this by providing guidance on development and the ways to evaluate economic impact, as well as running knowledge exchange events virtually, visiting the UK, Estonia, and Finland that have the most mature national efforts in this area. So this slide describes the project work packages along with the working groups of the 1+Million Genomes Initiative. And just to touch upon a few highlights of these, we have a stakeholder portal up and running, and we'll distribute early versions of the B1MG deliverables for feedback. And if you would like to sign up as a stakeholder, then please find a link to do so at the B1MG project website. The work package addressing ELSI considerations will produce a toolkit. Activities to date are focused on analysing the 1+Million Genomes use case needs and evaluation of the technical infrastructure components from the regulatory perspective. For the technical infrastructure required for secure cross-border or cross-jurisdictional access to genomics and health-related data, a blueprint has been released incorporating the current understanding of regulatory requirements, and the rare diseases proof of concept implementation will be generated by the end of this year. And to drive forward the aspects of personalised medicine delivery, a B1MG maturity model has been drafted, which is intended for decision makers at the national or regional level to be high level, provide recommendations with additional supporting documentation, and cover ELSI, health-related services and technical domains. And this draft is currently being reviewed by a panel of experts and then will be released by the B1MG project. To improve the understanding of how to implement genomic medicine across Europe, we promote knowledge exchange between EU countries, and we organise 3 virtual capacity building visits to the countries I aforementioned, the United Kingdom, Estonia and Finland. We held our last country visit just a couple of weeks ago, and if you go onto the B1MG website, you will find more information about those visits, links to the recordings, and links to the documentation. And finally, I want to talk about our drive towards sustainability. We are working to establish partner projects to aid adoption of our recommendations. We're supporting regions and countries to prepare a proposal to be included in their national plans and create a genome of Europe. We are producing guidelines and recommendations for national mirror groups. These are essentially reflections of the working groups of the 1+Million Genomes Initiative at a national or more local level. So in this slide, I'll describe the use cases that we're focusing on. Those are rare diseases, infectious disease, cancer, and common complex diseases. But an important aspect, and probably the most important aspect of this slide, is what's in the middle, and that is of the citizens' trust. Citizens are the ultimate data owners in this sphere. And we are currently scoping the activities to ensure that patients are placed at the centre of this initiative and are a core part of the process. So at the moment, we are driving adoption of recommendations and guidelines through the aligned projects, such as the European Joint Programme of Rare Diseases and Seneca, where objectives align. And the long-term strategy sits with the 1+Million genomes. And for success, we need to build upon the current activities through future investment. So personalised medicine is the future, however complex and uncertain it might look like now. We have seen recently how many of the hurdles around infrastructure and data sharing have been overcome in an infectious disease public health crisis that we're in right now, which is an opportunity to identify the recommendations that allow us to ensure that we move forward to redefine healthcare. And the most critical factors that I would argue here are that we have interoperable standards so that this will operate in an international federated system, and networks of trust at all different levels. So thanks again for the invitation, and I'll stop there. Thank you.
Well, very interesting presentation, and also the figures are very impressive. I have just one question, Dr. Saunders. It's about, you talk all the time about citizen trust. And it's true, I think if without the permission of the citizens to share their data, it's almost impossible to get so impressive figures. So in your opinion, how you can promote the citizen trust and that the citizens are able to share their information, their personal information at the end?
Mm-hmm. Mm-hmm. So I think there's two factors in my mind, you know, trying to use examples for both. And it's enabling the citizens to know that they actually do own the data. You know, they are the data owner, and this should be described repeatedly. And I can think of examples within Genomics England where this has been described well. Genomics citizens are able to offer their data to the project, but also know that at any time they can go to Genomics England and ask questions about their particular data, and these questions will be answered. And importantly, they have the right at any point to remove their data from the system. So I think the way that Genomics England has described this to the citizens of the UK has been very impressive. The second factor, I think, is in information sharing and describing in plans at a national or regional level how we can better describe what's happening with genomics data and what's happening at the interface of genomics data and medicine. And I can think of two examples, both within the Nordics. So in Finland, they have in their national press, their 5 highest selling newspapers all plan and do, as everyone suggests, carry a story about genomics medicine every week. So this allows the citizens to understand more a very technical sphere about genomics medicine, but allows the citizens to understand where developments are happening and where this data is being used, and really that information growing within the Nordics. An example of Finland helps with the public understanding, and therefore I think reduces some of the concerns that might be voiced if one is not so informed. And the second example I would use is from Estonia, where our contact, or one of my key contacts, Andreas Metspalu, described to me recently about how he was involved in describing a genomics medicine-based story within one of the most popular watched sitcoms within the country. So this level of information sharing across the country, I think, really helps, and these underpin what I would hope is a future of a trusted genomic medicine service across Europe and across the globe.
Thanks, Dr. Saunders. Well, I would like to kindly ask you to wait until the end of the session, when we will have an open discussion with the questions that we will have posted on the Slido. And now I'm going to give the floor to the next speaker, that is Professor Andrea Damiani, that he's from Gemelli Generator. Well, he's the head of research and development at Gemelli Generator. He's a mathematician, numerical analyst, specializing in mathematical and statistical modeling. Gemelli Generator is a multidisciplinary innovative center, which objective is to develop highly innovative projects and solutions to support clinical research and healthcare process improvement by collecting, storing, analyzing, and translating data into usable and understandable information. I can see that Professor Damiani is here. Well, thank you so much for being a speaker at the conference, and the floor is yours.
Thank you, and I hope you are seeing my presentation.
No, not yet. You have to share your screen. Wait, I think it's going. Yes.
Okay. And you confirm it's in the right format and not that for the presenter, right?
Yeah.
Yeah, which is pretty good. Thank you very much. Indeed, I'm the director of this initiative here. It's a facility dealing with real-world data. It's a very important thing that it's a very important addition to our hospital's research, because as we will see in the presentation, real-world data are the integration of the usual data that are used in clinical trials. And we decided to start with this initiative of Gemelli Generator exactly to make one step further in the field of research and to try new challenges in this field. This presentation is composed of 3 phases. The first one, in which we'll give an example of some new needs. These are really just examples. And then some new solutions. And what is our experience? So why we think that a structure like a Gemelli Generator is a good solution, is a good answer to the new needs. Okay, already in the 2010, the FDA recommended a new approach, a Bayesian approach to some kinds of problems, especially those in which deterministic dynamics were mixed with the stochastic parameters, so with uncertainty. Okay, and so the Bayesian modeling was perfect for that aim, but now in modern time, just 10 or 11 years later than that, we have something even newer than that. So what is the problem? The problem is that we have anatomy and physiology, use conditions, physics of device, and this is all physical modeling. And we want to do in silico clinical trials. So what happens, as I said, is that we have a combination of some kind of variability which can be described by the geometry, the materials, load cases, and so on, all stuff that the engineering studies and has been studying for decades now. So this is all very, very good. And then we have the uncertainty, empirical, stochastic, and so Bayesian methods. And this is something that we really need, because if we want to use all these in clinical trials, well, we need a different approach. When we reach model maturity, we will have more in silico trials than clinical trials, which is very good. Also, because clinical trials, as we all know, are expensive in terms of money, in terms of time, in terms of all the clinical doctors have to do to do them. While in silico trials may be done in less expensive ways. For instance, what do we expect from a synthetic cohort? Every member of the synthetic cohort should be a plausible patient. This is quite obvious, no need of comment here. The clinical accuracy of any predictor estimated on the synthetic cohort is representative of the accuracy of the predictor on any real cohort. And we also need it to be clinically meaningful. And 3, for sufficiently large virtual and physical cohorts, the conclusions of the effect of the intervention assessed from virtual and physical cohorts are identical. And why do we need synthetic cohorts? Well, of course, we need them in order to be able to do in silico trials. We also want to be able to measure performance. And we want to measure performance in a neutral way, if possible. So we need an integration of different data sources for process performance assessment. And we want to evaluate individual benefit and also the number of prevented events, because these are typical success metrics. So we want all these dots, the blue dots are patients, are individual patients, to lie in this gray part of the diagram and not here, where the risk with treatment is greater than the risk without treatment. So we want all the patients to be here and We want to be able to evaluate this via in silico trial. And this means that we need an integration of three components. First of all, knowledge and data, epidemiology, biological data, clinical trials data, real-world patient data. All these must be integrated in the evaluation. We also need a therapeutic model. Finally, we need a disease model. And when we put all the three things together, there is some complexity in it, but we can evaluate the actual benefit of a new treatment versus no treatment. And of course, all this is done on a virtual population, which goes back to the three parameters on which the definition of a virtual cohort is based. As I say, those were just examples of what is happening now and what is going to happen in the future. So we need new solutions. We need new solutions, we need something innovative. And of course, we are talking about big data. Because when we want the integration between data coming from different sources, we want to be able to address 5 main problems. The first of the problems is that of velocity, obtaining results as quickly as possible, and not just after months or years. Value, which is based on the extraction of multidimensional results. So from a data set, we want to extract answers about different dimensions. Veracity means being confident on data and models. So, I mean, we are in a hospital here. I work at the Gemelli Hospital. This is a very big hospital. We have tons of data. Our latest approximation is about 800 million atomic data about patients accrued in the last 4 or 5 years. So this is really a large amount of data. But if we cannot be confident on the quality of this data, that's of virtually no value. So we really need to have confidence on the quality of the data we have. We need variety, which means that we have to use all available data sources, and this means integration. And we also need, of course, volume. But as I said, here at our hospital, we have volume. We also need, and I want to say a few words about trust, because the question that was asked earlier was about patient trust, citizens' trust. Well, one of the elements of trust is, okay, I'm giving you my data. Yes, what are you doing with my data? That's a very good question, and we must be able to answer. And another good question is, and after you have used my data to learn one of your precious models, let's say deep learning, okay, a deep learning model. So how can I be sure that this model will be understandable, that this model will be very transparent in its workings, and that this model will not harm anyone? So how will I be sure, or how can I be sure? I am a citizen, I'm giving you my data. How can I be sure, to sum it up, that my data are not used against my good, against my family, against my people? This is the problem with XAI. So we don't want black boxes. This is also another very important element in building this trust relationship between people like me and the other in here where I work, who do data analysis and modeling, and citizens who want to be sure that what we are doing is ethical and will only lead to results that are good for everyone. This is something that we actually must address, and there is this XI framework aiming to produce more explainable models and to enable human users to understand, trust, and manage the emerging generation of AI partners. And that's something that we are implementing here in our lab. There are also advances in mathematical models. Why? Well, because we have had some progress in bandwidth, in computation speed, in available memory, algorithm parallelization, and costs are relatively reasonable. So researchers have a chance to tackle complex problems with modern tools. For example, those based on Monte Carlo methods, which are simulations that were available to huge computer systems 15 or 20 years ago, and are available maybe on my desktop now. That's a huge difference. Then we have the generative models, which define a wider and an open variety of probabilistic models in which parameters are treated as random variables, the Bayesian approach, and the distribution are approximated from data. And these models can be used to generate populations, so an answer to the cohort generation problem. And we have hybrid models, and with these, we are just on the edge, because I'm going to show you some examples from the past, but from a very close past, no more than a year ago. An interesting example that you can find in the reference here on the left is from the COVID pandemic, unfortunately, and it was presented in July 2020. And what is a hybrid model? This is very interesting. There is another paper published on December the 31st, 2020, so 7 months ago. This was about repurposing, drug repurposing in the COVID-19 crisis. These are the author's words, and they propose a deep learning and molecular dynamic simulation-based hybrid drug screening procedure. So they wanted to know if some drugs that were, in their opinion, good candidates for fighting the pandemics, if they really had any chance to be useful. And what they use is a hybrid approach in which there is deep learning from those things of which we do not know the mechanics, because we do not know the mechanics about this phase of the study. So we do a simulation based on learning a model on deep learning, so on neural networks, essentially. Then we have other parts, other phases in this workflow that are actually deterministic. So the screening, which is structure-based, this is deterministic, and we can mix it with a non-deterministic, just probabilistic screening. And then again, another kind of screening, which is halfway, which is part deterministic and part probabilistic, which happens here. And at the end, there are candidates. So since this is a screening, the success happens when you start with a large number of candidates and you end up with a small number of actual candidates to be tested, to be field tested. And as you can see, they started with 1906 candidates, and at the end they had just 4, which is great, because all this is done by computers. So hybrid models are in our future. What is our experience at Gemelli Generator? And what is the connection with with what you see at number 1 and number 2? The connection is in the fact that we thought we actually had to put up an effort to build an infrastructure in which those things are made possible. I'm not saying that we are doing all that today. What I'm saying is that with our infrastructure, things are gradually happening and we are following this flow of innovation. This is our distribution of available real-world data. This number, which is 700 million 60, is just an approximation. We are now, well, over 800 million atomic data. So all data are semantically tagged, quality control, and constantly updated, of course. And they come from day by day clinical practice. They come from different sources, as you can see. So some extractions are custom made, for instance, those from radiomics. And we are also starting to deal with genomics, transcriptomics and proteomics. There is a facility which is just next door from me, and they are doing genomics. And we can integrate all the data with the data warehouse and with the real-world data. And potential high-variance sources are sample-checked under direct clinical supervision. This is the general architecture of Gemelli Generator. I will go through it quickly. Of course, there are proprietary research repositories, maybe in some departments. They are storing some data for their private studies. But then there is the data warehouse. And from the data warehouse, data come out fully anonymized. We do some real-world data integration from apps, IoT, wearables. There is this XAI, explainable artificial intelligence here, bot and other bots are here. They are used to produce explanations of the models that we put at work. Because no doctor wants to work with a model if the model is not explainable. So the doctor wants to know why the model is working in a certain way. Doctors also want to know which covariates are more important in the model. So what we do is integration and support of clinical practice, visualization, data clustering, research studies, and we support trials. And there is something pretty much interesting here, because in the presentation earlier, I saw that there is a federated learning consortium going on, and I'm going to explain that we are also involved in this, because this is part of the future of research and part of that trust building with patients and with the population. So we are ready to implement advanced algorithms for AI, guided parameter, tuning and validation. We are also ready to generate synthetic cohorts via some clustering methods. On the other side of the wall, there is something very important to say, that we do not give our data away. That's another element of trust building. So patient data remain inside, and remember that here they are fully anonymized. So we are not adding any further danger to privacy and data ownership. And since the beginning, we thought that it was important to embrace the paradigm of open innovation. So the exchange of knowledge. And the question is how to have a significant role in open innovation while preserving data privacy and data ownership. The answer is the separation of data from knowledge. So we can produce actionable knowledge without giving data away. So we have to shift all data processing inside the laboratory walls, and it's made possible by combination of infrastructures and algorithmics. And this is the first example. If, let's say, an external partner wants to learn from our data, they send us the model, we implement the model internally in a sandbox, or they can send us, let's say, a container, a Docker. In this Docker, there is the algorithm. We will only be watching the results that come out from this container and go back to our external partner. Our data will not exit the hospital, and the algorithm can remain proprietary with the external partner. We need not examine the algorithm. We are just watching the communication channel. In this way, knowledge can be exchanged, knowledge can be created, and value can be created without sharing our patient data. We can also do validation of external models on real-world data in this way. This is the architecture that we are currently using. And another important solution is that of distributed learning, to which I was referring before. We achieve privacy by design in this way, and a model is learned without sharing data among institutions. It's actually the model which goes around, so we learn the same model in one institution, in the other, and the last one. Then we combine the results together, and if we need a better approximation, we go on cyclically until the result is satisfactory. And at the end, we have a model. And the important thing is that this model is obtained, and it is the same model that would have been obtained if the data had been collected in one place. So we can learn from data with many different models. Virtually anything can be done in a distributed way now. We enforce data privacy. And we also enforce data ownership, because it is a fact that once your data leave the hospital walls, they are no longer yours. In this way, they do not leave the hospital walls. Finally, a couple of examples of what we mean by XI, explainable artificial intelligence. We build interfaces that are easily understandable for doctors and that the doctors will happily want to use, because this is the secret under everything. If what we build that does not make the doctor happy, the doctor will not use it. In this small example, it is possible for the doctor to select a patient's clinical parameters and then ask our system to provide statistics for similar patients. Similar, of course, based on a given group of variables. This is a colorectal surgery dashboard which deals with problems after the surgery. So we have the sensor, we have pulmonitis, we have other possible pathologies that can arise after a surgery, and in this way the doctor can ask the system what happens usually in our experience with patients just more or less like this one. It's just the same as having an older colleague, maybe 80 or 90 years old, with perfect memory. This old colleague remembers everything that's been going on in the hospital about that class of patients, and is very good at statistics and produces very nice graphics, and so it makes things very much understandable for everybody. And all this happens in less than 1 second. So it is very useful. The doctors use it. So they use this interface to study the patient's potential evolution. Okay, and here the doctor can specify a combination of parameters, and the system can give the list of different patients who underwent the same surgery and had more or less the same parameters, and also compute a complication rates for different kinds of complications. And here, the interface gives you a comparison between patients who are similar to the one you have in front of you and the total of patients who underwent that procedure. And this is useful because it gives you an idea of the increased risk. So, this is what we are currently doing here at the Gemelli Generator, and I hope it was interesting for you. Of course, what I presented here is on a different level than the former presentation that was on a system level. This is at a hospital level, but we really hope that our experience, we have a helicopter here at the hospital, as you can hear. We really hope that our experience can be reproduced somewhere else and that we can start networking on that. Thank you very much.
Thank you very much, Professor Damiani. Well, at the end of the session, we'll have questions, but I have one question about, well, you know that the COVID-19 situation, faster some processes, such as the data protection processes. So, based on your experience, do you think that, thanks to the COVID-19, we had some improvements as regards the process regarding the data protection, or everything remained the same, or it was a change in Europe about this?
What I'm observing is that citizens are more and more aware of the fact that giving their data can save lives. Mm-hmm. Okay, so before the COVID-19, it was a kind of knowledge reserved to those who actually had problems, and so were very big fans of research. But now, more or less everyone, with the exception of a few, well, more or less everyone is a huge fan of research. So that's one element. The second element is that federated learning and data quality assurance and validation, external validation, I mean, has entered the Horizon projects in Europe. It is officially in the Horizon projects, so Europe is putting money on it, which means that this is considered a very important problem at the highest level. I'm not sure it was the COVID-19 or was something else. For the general population, it was. For the EU, maybe it was a process going on that's been going on for years now. But anyway, it is very good because we need networks if we want to reach any conclusion, any good result. And the only way to build networks is via these algorithms that do not share data but share knowledge.
Thank you very much, Professor Damiani. Well, I'm going to give the floor to the last speaker of the first session, that is Dr. Edbokimos Konstantinidis. Well, he's Greek and it's quite difficult to pronounce the surname. He is a postdoctoral research associate, is the leader of the Assistive Technologies and Silver Science Research Group in the Lab of Medicine Physics, Aristotle University of Thessaloniki. He supported the establishment of the Active and Healthy Aging Living Lab in Thessaloniki in Greece, that is called TIS AHAL. And the TISA hub is a hub of interconnected pilot sites that enables user-driven innovation in active and healthy agent and related domains. It is a certificate member of the European Network of Living Labs, of ENOL. The group embraces co-creation approaches by having built a strong network in the healthcare domain. Thank you, Edwakimos. The floor is yours.
Thank you for the introduction, and thanks to the previous presenters for the useful insights. Here I am today to discuss about the harmonizing health living lab infrastructures, procedures, and services, and how we do this through a project. Okay, so European Network of Living Lab, our motto is that we should empower everyone to innovate, or we should enable everyone to innovate. But what is ENOL? ENOL is the European Network of Living Labs, an international non-profit association which aims to promote and enhance user-driven innovation ecosystem, and more precisely the Living Labs concept globally. So the European Network of Living Labs is the association of living labs in Europe. We have a variety of areas where our living labs are engaged, starting from my interest, actually, health and well-being, but as you can see also we have social innovation, smart cities, education, artificial intelligence, and many other topics, which proves that living labs can go beyond health and well-being and can be everywhere and can support research in many different domains. In the European Network of Living Labs, we have 5 main action-oriented task forces: social innovation, digital rights, social impact of artificial intelligence, health and well-being, rural living labs, energy and environment. I'm leading the health and well-being, and this is what I'm gonna present today. So, living labs. Living labs are actually methodologies try to come up and improve with methodologies that augment co-creation by bringing together government, industry, academia, and people. And they try to provide the values of co-creation, orchestration, multi-method approach, real-life setting, which is very important, multi-stakeholder participation, and active user involvement. So in the European Network of Living Lab, we have the labeling certification, which means that for a living lab or an organization to become a member of our network should go through a labeling certification procedure where we evaluate some of the aspects like organization, openness, co-creation, value creation for the involved stakeholders. But in order to do this, we have to harmonize the work, the living labs work. And this is what I'm going to present now, a project, a methodology and approach open to everyone on harmonizing the procedures. So Vitalize, it's an H 2020 project which started 3 months ago and has a duration of 36 months. And the main idea is to harmonize the living lab, health and well-being living lab procedures and services. We are 19 partners across 10 countries and 2 continents, composing of living lab networks, individual living labs, research partners, academia, and SMEs. So the challenge of the research community is that researchers need access to key research infrastructures. This is sometimes challenging as they have to waste a lot of resources on identifying and accessing these infrastructures, especially in the domain of health and well-being, where humans are under observation. The challenge becomes even harder. In the case of living labs, this has caused the creation of many project-oriented living labs that serve specific research purposes and have a life cycle similar to a project. So, for instance, if I'm a researcher and I want to do something and it's not easy for me to find another living lab or actually to utilize another living lab or the infrastructures of another living lab, I have to invest in resources to develop my living lab, to conduct my research study there, and then to leave the living lab die because I don't want it anymore because the project has finished. So actually, this is what Vitalize tries to address, to to give access to the researchers to existing health and well-being living lab infrastructures. And the impact of it, first of all, is actually we try to avoid duplication of services by giving efficient access to research infrastructures. We allow for more advanced research infrastructure services. We contribute to the wider sharing of information, knowledge, and technologies across fields. We foster innovation by bringing together research infrastructures and industry. We try to have a new generation of researchers ready to exploit all these tools that I presented, and we contribute to the evidence-based policy making. So the concept is, we start with the harmonization phase, phase one, where we actually try to understand all the services that health and well-being living labs can provide. To give an idea, just for you to understand better, when we say service, we mean services that have to do with study protocol, ethics, recruitment, infrastructure, piloting, evaluation, and many others. Then we have the second phase, the joint research activities phase, where we have some research studies that will use the harmonized service and procedures in order to evaluate how well they have been harmonized. And these studies, I will give some information later on this. And then in the third phase, we invite external researchers to join these research studies in order to use the harmonized service and procedures and to evaluate their effectiveness. So if we could say that Vitalize is about to answer one question, that would be how much convenient and effective the access to the living lab infrastructure becomes with Vitalize. And when we say harmonization, we mean harmonization in the procedures, but also in ICT tools. And by procedures, we mean like protocols, data collection, evaluation, while on the ICT tools, we could say that it's data processing, data sharing, structures, etc., data structures, etc. Here you can see a first approach of the service and procedures that we have identified, but we have been working the last 2 months a lot on interviewing living labs, health and well-being infrastructures in order to understand better what they can provide. On the tools, you can see that we are looking for some existing hardware and software middlewares and APIs, as well as innovative ways on data sharing and processing, like the previous speaker mentioned with the Docker approach, where people can process, researchers can process the data without having access to the data. So the harmonization procedure will be an iterative procedure where we will go through these 7 steps, where we identify processes, we study, we have a consensus, public review, and again and again and again, in order to come up not with just harmonized procedures, but actually a methodology that will be evolving throughout the years and even beyond the life cycle of the project. The 3 research studies that we have, and on the bottom side of the slide, you can see the partners that are involved. We have rehabilitation, transitional care, and everyday living environments. We have 17 living lab infrastructures across 7 countries, where more than 300 researchers will have the opportunity and the budget to visit and to conduct their studies there. Here you can see some photos, and here is the plan of the open calls. We will have 3 open calls, and we have already the budget to support external researchers that will visit the infrastructures. The target group, it's all disciplines that have to do around health and well-being, and we know that there is a big variety starting from psychologists, doctors, down to UX designers. We invest a lot of effort also in capacity building. So instead of just harmonizing, we harmonize, but at the same time, we create the material that will allow external researchers to understand how these harmonization procedures work and how they can employ it in their research studies. Here you can see overall the outcomes, but also the tasks that we have to go through. And I would like also to say that there are many living labs, and all is just one network of the many that exist. but we managed to bring together 3 networks in all, which leads the proposal, the project, EIT Health Living Labs and Forum LLSA Living Lab Network, in order to work together and to build something that will go beyond the ENOL network. It's our time to work with the living labs, to work for the living labs, but actually to work also for the researchers. So we try to keep it as open as possible. And since one of the key principles of living lab is openness, Vitalize, we try as much as possible to have Vitalize as open as possible in order to contribute to shaping the future of living labs. And this is why we have most of our events, even the KickOff meeting was open and will be open for all the interested researchers, living labs or other stakeholders, not only to contribute, but also to get access to the outcomes as soon as they materialize. So please feel free to go to the Vitalize Project EU website and you can join the Vitalize Harmonization body, where you can be involved in all the discussions about what to harmonize, how to harmonize, and to shape, let's say, the harmonization toolkit of living labs, to be a member of a transnational network, and to participate in joint publications about the living lab harmonized processes. Finally, I would like to invite you also to the flagship event of the European Network of Living Labs, which is in the 6th to 10th of September. It's the Open Living Lab Days, but due to COVID last year and this year, it's called Digital Living Lab Days, as it takes place virtually. Thank you for your time. Any questions?
Thank you very much, Evdokimos. Well, I'm going to give the floor, we are running a little bit out of time, so I'm going to give the floor to Anna if there are any questions in the Slido, and she will read you the questions to the 3 participants of the first session.
So firstly, thank you very much for being our speakers. They were very interesting topics. It's very interesting knowing how to use the data and all to boost the researcher network. So I'm afraid that we are very late or running late. So I will ask 2 general questions. In your view, as important researchers from cutting-edge institutes and from the academia, which are the main challenges that as researchers have to face while you are trying to test your innovative or research outcomes outside your organization? So
just one thing, Anna, because I can see that Gary and also Professor Andrea, yes, to turn on the camera, I would kindly ask you, thanks. Yeah, now we can see.
Do you hear us, or I need to repeat the question? If you, excuse me?
Oh, I heard the question.
Okay.
More or less, yes. So you want to know what the challenges are in doing research with other organizations?
Yes, yes,
yeah.
Of course. Yeah.
Well, I don't know if my colleagues want to answer also before me, but if I have to answer, we are a hospital. So if you want to do research with other hospitals, then you must provide them with the whole infrastructure, and you must teach someone, maybe in the IT department of each hospital, how to implement it and use it. So this is not a small effort, not really. But it can be done. We have done that in the past. It can be done if you put an effort on that. Yeah. Then, when this is overcome, well, there can be other problems because, for instance, in some models you have to use a specific kind of hardware. I'll give you an example: a GPU for neural networks. deep learning is enhanced, is much faster when you have a GPU. Then you have to go to a hospital and tell them that you actually want to use a GPU. And they will ask what a GPU is. And so you understand this is a big problem. But apart from this, the only other problem remains availability of data. If we want to do a research on real world data, then we should find other partners who have an adequate amount of well-maintained real-world data. This is not easy to find.
So it's difficult. And I have
Can I offer an answer to that question as well? I really liked the discussion. And I think from Elixir, we see a number of the difficulties in working across different institutions and different countries and different jurisdictional regions. And I think I would break it down into maybe 4 key aspects on the technical side, and then maybe 2 key aspects on the non-technical side. So on the technical side, I think there's firstly a challenge about discoverability of data. So as Andrea said, availability of data, but the first step there for me is discovery. How do I find someone who has data similar to me or data that I'm interested in? And then the second aspect there is access to these data. Okay, I've discovered that it is somewhere and I can find someone to potentially collaborate with, but how do I actually access the data? How can I computationally find a way to try and find access to those healthcare data across a jurisdictional region? And then that leads us to the step of authorization and authentication. So how do I, as an authorized researcher, show my credentials to someone who's a data owner so that we can build collaboration? And then the final aspect there is data processing. So we know in the world of GDPR, when we have data controllers and data processors, how do we, in a collaborative environment, decide who can be the data processor and who can be the data controller? I would say those are the technical aspects, and we have solutions to try and address those, but still there does need to be a widespread adoption of the standards and the methodologies by which we do that at a global or maybe even a regional European level. The second aspect is the non-technical questions, and I think these are really key questions about trying to grow the field. The first one is, who pays for this? So, if we have a collaboration and we want to do some computation in a federated environment, who pays for the storage, who pays for the compute, and how do we try and build cost models that make these things fair across Europe, across region, across the globe? And then the answer there, the second qualified answer there is, who pays for the storage of the analysis, and then how can we access the analysis going forward? So I think the question that you ask is absolutely vital. Some of these things have been addressed by the European Open Science Cloud to try and build these cost models, to try and build these federated environments going forward. But if we could try and have some stock answers and some stock solutions to the questions you asked, this is really, really going to open up personalised medicine across regions and across Europe.
Thank you. And
can I also ask a question, Anna?
Yeah, of course.
So thanks a lot for this first part of the meeting. It's been so interesting. I have a couple of questions, mostly to Dr. Damiani and Dr. Saunders, and the comment on the last thing that Dr. Saunders said. The first question for the Gemelli generator is, so you receive, your model receives data from different institutions or departments. How do you guarantee the quality? Because at the beginning you stated that the quality is very important. So how do you guarantee that the data you are receiving respects the standard, the qualitative standard that you have set? I'll just answer, like, I'll just do all the questions. The second question is for Dr. Saunders is this kind of models like Professor Damiani's model interoperable with your infrastructure? Do you expect something more at the regional level to not disperse the work and the value? So, like, do you believe that a single hospital can cooperate with Elixir, or you would like to have something at more regional level? So, like, more hospitals cooperating at the central regional level, and then this node cooperating with Elixir. And my comment to who pays for this comes from Andrea Damiani's suggestion of the open innovation. Can this data, with cooperation with the public, since they have a huge value, also establish a lot of financial sustainability? So like maybe when we cooperate with the private industry, we could have a reimbursement model for this and make everything sustainable. Thank you.
Okay, I think I have to go first. So the question was about data quality. Yeah, that's an issue, of course, but we have some advantage with real-world data. They come from centralized software because each hospital, not all hospitals have one. I have to be frank. I'm not going to lie. Not all hospitals have a centralized software with all the whistles and bells in it, all the quality controlled input interfaces and everything. But luckily we do. So we have a centralized software in which doctors input their doctors and clinical professionals at large input their data. So yes, we are lucky. Because the average quality of our data is pretty good, because they are exactly the same data that are used in clinical practice. So they have to be good. So we inherit something that has already undergone the quite severe requirements of a hospital quality control. We also had a recent certification with a JCO, and we passed with very high marks, I'm happy to say. So we are pretty confident. And we are so confident that we also have our procedures in place. So if we know that some variable is supposed to be normally distributed, we do check for normality. We do check for outliers. We do check for impossible out-of-domain values. Nobody is 4 meters tall, always more than, 300 kilograms, okay? So some things cannot happen. Some things are revealing of, for instance, a measurement unit mismatch. Outlier analysis is also important. Some variables are domain limited. If you take tumor grading, it can only be 1, 2, 3, or 4. There's no stage 7 tumor. So if you get a 7 there, something is seriously wrong. So there are a few controls that you can add here and there. And actually, we do that. Also, even if we have this great big guarantee in the data lake, how our IT people call it, the data lake. So the data lake is already very well certified, but we do our own quality check. And the same goes for other data sources like the wearables, IoT stuff, and stuff coming from images and from genomics and whatnot. So yeah, that's needed.
Thanks a lot.
So I would like to. Excuse me.
There was also Dr. Saunders, if you could answer.
Yeah.
I'll try to be brief. I'm not sure how we're doing for time. But data quality is a huge issue, and the need for metrics to allow us to understand the quality of data is a huge issue. And one of the projects that I described that we're working on, the CSA of beyond 1 million genomes, that has a work package to assess what the quality metrics could be for any given data from the genomic sphere, from any genomics laboratory, from any hospital, from anything else. And I think there's two aspects to that. I think it's one about setting the standards and having the standard approved, and then it's about having tools that allow you to validate the data. So having the data generated is fine, but then validating that data and making sure that it aligns to the quality metrics is a second sphere. And then there's actually a third thing there about having a portal or having a way of how we can discover data that meets those metrics. Those are the three things that I think we're working towards, and it's, we have some deliverables that are heading towards that for genomics data now that we should see later this year. We're still quite a long way from having that EOS, view of how here is all the available data for your research question. But it's a nice way to look at it. On the standard, on the federated environments in which the Elixir system be interoperable with any of the other systems that we've heard today. So I'm a huge advocate of open science based on open standards, and make these things as interoperable as possible from the very get-go, from the first mile. And I can give you examples of where we have within the Elixir infrastructure solutions at the national level. So say Finland, for example, where they like to store their data in the repository of the CSC. Or examples where it's regionalized. If you look at Norway, where they have 5 healthcare jurisdictions and they have agreements across all of them to try and share the healthcare data. Or in regions where it's not possible. So if I think about Germany, where it's a jurisdictional environment where they have 16 or 17 jurisdictions that hold the healthcare data. Now, if these things can be based upon interoperable standards, then hopefully the plan would be that the technical solution is there as we start to address the political questions and start to address the GDPR questions about how we can share these data or access these data across the boundaries. And I think it comes down to your last point, Gianni. So you asked about the socio-economic benefits. And I really think if we can start to describe well-documented and well-analysed solutions that show the socio-economic benefit and show the cost benefit of a lot of the integration and the implementation of these solutions, that's where we might start to see the political will drive even faster. And if the political will drives faster, then I've hopefully argued that we have, via open science, via open standards, the technical solutions there that can help us drive towards a sphere where we can share access to these data and drive the socio-economic benefit across Europe, across the regions, across the globe.
Thank you so much, Gary and Damiani. I have one quick question for Evdokinos. In your view, what are the main steps that should be done in a completely implementation of living labs across Europe?
I think that the living labs have already a lot of value to provide, and a lot of power. What is missing in order to unlock the transnational collaboration? So we give somehow either to researchers or to companies that want to conduct studies, research studies in health. They enable them to run the same study in Greece, Spain, and UK at the same time. We need to harmonize. So somehow we know that we speak not similar language, but the same language, in order for the researchers and the companies to trust us for the implementation of this. In general, the concept is really powerful and nice, co-creation and value creation for many different stakeholders coming from many different domains. The harmonization is the key to unlock this all this value, at least this from my point of view at least.
So thank you so much. The floor is yours, Jose.
Thank you very much for the questions. Well, now I would kindly invite our first 3 speakers to wait until the end of the conference, when we will have the results of the poll that you will present. And I would like now to go to the last session of today, that is financial instruments to support innovation. We have the pleasure to have on board in this conference Cristina Vescos, that she's the managing director of the IT Health Spain. IT Health Spain is an independent body funded by the European Commission to foster innovation and entrepreneurship in health. Their main goals are the prevention and promoting of active aging and improvement of chronic patients. Mr. Vescos will present the IT finance and programs to promote research and innovation in the healthcare systems. Thank you, Cristina. The floor is yours.
Yes, thank you, Jose Maria. Can you hear me well?
Yes, perfect.
Yes, super. So many thanks for inviting me here. As you know, I'm taking the place of my colleague Irene Sanchez, who is the director of Accelerator in EIT Health, but she's due to sickness, she cannot join today. So I have prepared some slides about what we do in EIT Health, especially in terms of funding opportunities for innovation programs and projects and startups. I will be a bit quick as I understand that we are a bit out of time. So how long do I have, Jose, just before I start?
Well, yes, we're running. Can you hear me, Cristina?
Yes.
Yeah, sorry. Yes, we're running out of time, but well, it's what we thought it was about 10-20 minutes maximum the presentation and then questions. So at the end of the session, we will ask questions together to Orestes, the next speaker, and to you as well.
Okay, so I'll try to be fastest. Thank you. So you can confirm you can see my screen. So I will explain as Jose was saying what we are as EIT and EIT Health. The EIT stands from the European Institute of Innovation and Technology, and it's a body of the European Commission created in 2008 already, to really tackle the challenge of innovation in Europe. And there are at the moment 8 communities created depending on specific challenges of Europe. And I represent the one on health, who was built in 2016. So we have now 6 years of life. And in the end, we are public-private partnership of all the actors involved in health, in innovations in health, from universities, research and technology institutes, business, healthcare providers, payers, in order to together really boost the innovation pathway in Europe. We have 3 aims, as triple aims. So one is strengthen the healthcare systems, especially in terms, we know, sustainability with the high demand, not only due to pandemic, but also for the chronic and aging populations, promoting better health for citizens, and contributing to health as a really a sector for competitiveness for Europe, so that health is not only looked as an expenditure pot, but really as a sector where we are employing high-level people, and also really a potential for growth for the European countries. We are covering the full of Europe, so you can see we have notes in each one of the green spots that you have on the picture, and all the pink areas is forming an extra node that we call InnoStars. So in the end, we are covering all Europe in order to, as I say, to bring, in one sense, this European international dimension, but on the other side, to foster the local ecosystems in innovation. We are working in 3 pillars, and this is in order to foster the type of projects. One pillar is Accelerator, really dealing with supporting entrepreneurs and startups. Second pillar is about education, and it's not only about supporting academia, masters, or PhDs around innovation, but it's mainly about changing the work style needs new capabilities in digital skill, but also in the way of working, in understanding and cooperating, co-creation, and so on. And the third pillar is innovation, and we've seen, and you are part of an innovation or research project from Horizon program. We are entering a bit later, so we are promoting also collaborative projects, but really very, very close to the market. I'll explain that in a moment. So in only, this is the results of 4 years, but we are now compiling the results of last year, but we have already created an important impact around Europe, both in terms of economical impact, but also on impact on people and citizens. in terms of startups, and this again is the numbers of 2019, we have supported almost 800 teams, and those have raised up to 250 million euros, just considering until 2019. I have the numbers of 2020, but only for Spain. So you can see only in Spain, we have our startups had been able to raise funds for almost 67 million euros. So you can see that last year has been tremendously exponential for everything that is health and in terms of financial, that is the topic of today. I wanted just 1 second to talk about the different pillars, but you have a glance of what we can fund, and especially in terms of linking to a European project, because normally, as you were saying, it's not only about implementing a new solution or a new way of gathering data, but there's a change in the culture, both in the citizen side, but also on the professional side. That's what we promote with our education programs, that can be in terms of fellowships, summer schools, masters, PhD, and others. In terms of innovation, I was saying we really take normally consortium that are more mature than what you see in the programs of Horizon 2020, Horizon Europe. So we are the next step, and we have been able to bring already 55 products to the market. And in this respect, we also invest heavily in specific challenge programs. This is a program that we call Wildcard, that we launch 2 challenges per year. The challenges of next year are to be defined, so maybe it's about personalized medicine. This is one of the topics that we have in the pipeline. And we invest up to 2 million euros in a specific project in order really to build the team, validate the business proposition, and really make the right investment decision and collaboration. I will concentrate in the part of accelerated, because I think it's the element that it's more linked to the type of funding that we are giving. In this context, you can have the full accelerator program in this QR if somebody's interested to get a screenshot, and it's also represented on our website. Our accelerator program is divided depending on the really interest of the project or startup. Is access to knowledge in terms of mentoring or bootcamps, access to market in order to expand from a national market to another geography, whether in Europe or outside, access to stakeholders, to link to corporates, healthcare providers, or other important stakeholders in the community. And the last one, that is the one I will concentrate more, is access to investment or funding. But again, in general, Reality Health is not only the funding that we can give, it's the other elements. And I put always this example about Catapult. Is a program that we provide the opportunity of startups to pitch in front of really a community of venture capitals and corporates. And the price that we are giving as Reality Health is only 40,000 euros, which is really non-significant. But the winner can not only pitch in front of more than 1,000 really key opinion leaders of Europe, is that the winner of the audience has one day the name on the NASDAQ building. So you can imagine the visibility and the impact this can have above what really is the funding that we can give. But talking about funding, and that's the session of today, we have specifically 3 programs related to raising funds for startups, and I'll talk 1 second about each one of them, and I'll also incorporate a 4th one that is really new of this year, and this is starting in the next months. So the first one is the Investor Network, and it's for a startup that are really seeking funds up to 500K. It's an international network of investors. There's a selection of the different startups that are really evaluated, and then the investor can really syndicate an investment together, as I say, with other business angels or early VCs in collaboration, say, with different countries. We always say that the best way to internationalize a program is really to attract money from that country. It's the best entry door, no matter what kind of soft landing you can do. The second program we have is an international crowdfunding element. This is the first one also in Europe, so that we can raise crowdfunding rounds across Europe in collaboration with ISQVest, which is a renowned German player in this field. And the third one I wanted to mention today is the Venture Center of Excellence. It's a collaboration with the European Investment Fund to really raise big rounds from 20 million euros in Europe pre-IPOs, that we don't need to go to American or other geographies money, or to really have going to the stock market too early. That is one of the main problems of the European companies. This is really starting this year, and we hope to have a really very big impact. Also, it's a collaboration of venture centers and selected corporate ventures of all over Europe. And we'll have a lot of news for this year around the Venture Center of Excellence. And the last program, as I was saying, the fourth one, is a collaboration now with Horizon Europe. I hope you've seen that EIT now is fully integrated in the pillar of innovation, the third pillar. And there was an agreement between EIC, the Council of Innovation, and the EIT to really collaborate to align the innovation and funding opportunities. This is a program that has just started, so we have signed really the start on the 9th of July. And what it brings is the opportunity to use the investment funding of the EIC into all the programs that we have at EIT. And on the other hand, we can also utilize the capacity of the network that EIT is bringing in terms of bootcamp, mentoring, internationalization, and so on. And the capacity also to organize joint events as part of the complementary offer that EIC was giving, that before was mainly funding. So this is a way, as I say, to align all the European instruments more and more in terms of Horizon program projects, in terms of EIC, in terms of EIT, and also the EIF, or the European Investment Fund, that we have a sense to each one has its particularity, but we can all work together and more aligned than in the past. This was a bit, in a nutshell, what are the different opportunities that we can offer from the EIT Health perspective, and I hope we have opportunities to work together. I give you here the reference contact also my colleagues, so Irene and Gerard, who are really dealing with this part of the accelerator program, and I hope that helps to give a bit of, as I say, EIT Health and funding opportunities at a glance for your community. Thank you.
Thank you very much, Cristina, for your presentation. I think, well, we have a big overview about all the financial instruments that EIT Health has. I'm going to give the floor now to the next speaker, because it's very connected to your topic. That this is Mr. Orestis Kagiantis. Well, he's policy officer from the European Commission, and he will present how the European Commission promotes innovation in the healthcare sector through different procurement tools. Also, he will take the opportunity to present the new research and innovation funding program. Thank you very much, Orestis, for accepting the invitation. The floor is yours.
Jose, thank you very much. But can you hear me and also my slides?
Yes, we can.
Okay.
Perfect.
That's great. So many thanks to you and Anna and the organizers of TLS and Cedras for inviting me in this excellent panel of speakers you have today. And always pleased to see Christina's presentation as well, because I was going to make a reference on the EIC work as well, and it's very good that how it works together with the EIT. So much appreciated the invitation. Jose presented me already, so the only thing I'm going to say to you, apart from the
sorry,
yes.
Sorry, Restis, because we can see that you have to minimize some windows that you have open.
Do I?
Yes, because if not, we cannot watch the presentation correctly.
So what do I need to do?
Because it's on the top and also on the right that we see two windows.
Sorry.
Yeah.
I have to minimize this one, you mean?
Yes. Minimize or try to put out of the screen.
Yes,
or maybe on the top. On the top will be okay.
Okay, so this one, move it on the top.
Yes.
Will this work?
Yeah,
because
perfect,
I don't see any options.
Perfect.
Okay. Sorry for that. So I'm working for digital connections for e-health, well-being and aging, and a particular area of interest and activity of mine has to do with innovation, procurement, and digital health. So this will be the focus of my presentation today. Regions for Permed is a very interesting project that touches upon many of the issues we consider important for the development of our future health systems. For example, the use of data and the benefits it may yield. But it also highlights the regional aspect, which is an important factor to achieve a fair deployment of health innovations for our citizens in the EU, while taking into account the local preferences and conditions of the field. Now, I won't touch upon these matters, of course, in order to stay faithful to the event's schedule and purpose. I would like to present to you something much more focused, which is our approach and at the same time funding opportunities for innovation procurement in healthcare through the newly launched Horizon Europe program. And we believe that they constitute useful tools for the promotion of personalized medicine, not in an abstract way, but in helping address specific public needs and helping bridge the gap between the development of innovation and its actual deployment and use by patients, doctors, and carers. So, okay, great. So our support for healthcare innovation procurement through Horizon Europe consists of a mix of core topics for policy and coordination, as well as for the purchase of research and the deployment for health innovations. So I will present to you in a minute the coordination and support action, which is the policy part, as well as a pre-commercial procurement topic, a PCP, and a public procurement for innovative solutions topic, so-called PPI. Now, I will not present the instruments in detail, as there are distinguished guests tomorrow who will speak for the benefits and the challenges and their experiences in using these instruments. But whenever I can, I will remind you of some of their features. So allow me to say a few words on what we call first the intervention logic in Horizon Europe and what we want to achieve in terms of policy through the program structure and the way the call topics for the new projects are presented. I think this will make them more understandable for you. You can see here the overall structure of the Horizon Europe program, and the main element that I'd like you to remember for this presentation is that the topics presented are under Pillar 2, so Global Challenges of European Industrial Competitiveness, which is organized in several clusters. So the work program for Cluster 1, Health, is where you can find the relevant call topics. And of course, I will also point you to Pillar 3 and what the European Innovation Council does. And there you heard a bit also by Christina on that. It does offer also opportunities for innovation procurement for procurers and for industry stakeholders. And it might be interesting for you if you are a potential applicant there. Now, while the Horizon Europe legislation defines the structure, which you just saw, there is a 4-year strategic plan for the program, which defines our policy priorities at EU level and translates them into what we call key strategic orientations and expected impacts to be achieved. And this will be achieved, of course, through the research and innovation that we will fund. So the selection of projects actually through Horizon Europe contributes to the achievement of these overarching policy goals. And it is important to keep this in mind when considering to engage in a cross-border EU project in this framework. Now, these key strategic orientations and expected impacts for the health cluster are analyzed in the work program, which is in turn further broken down to a few thematic areas that we call destinations. And these include topics, calls, as we call them, that I'm going to present. Now, I hope that you're not too confused already with the terminology. The reason I'm explaining these elements is because the key strategic orientations and the expected impacts in Horizon Europe are an integral part of each topic. So all proposals must address them together with the specific topic objectives. And this will be clearly visible to you in the funding and tenders portal, which you see now on your screen, where the destination text is displayed side by side with the topic description. So this is all meant to say that Horizon Europe puts a particular focus on how the expected outcomes of the projects contribute to the defined impacts. Outcomes in our case are described at the level of the topic and refer to the immediate use of project results, whereas the expected impacts are described in the destination text and refer to wider benefits for society. And that is the key link. Applicants have to consider how to create impactful projects, and they have to show in their proposals how the outcome of future projects can contribute to these expected impacts. Now, let me turn to the content of our policy and look what the expected impacts are for healthcare and for innovation procurement topics by having a look at Destination 4. And here you may be able to see that Destination 4 is entitled Ensuring Access to Innovative, Sustainable and High-Quality Healthcare. And it already defines some basic areas which should be addressed by applicants, which is promoting good health and high-quality accessible healthcare, but also the resilience of healthcare systems in the EU vis-a-vis emerging threats. And of course, there are some complementary and good-to-have areas which depend on the applicants' plans as well, which is a contribution to the twin climate and digital transitions, including in the healthcare systems, and the contribution and the benefits of the data economy. So the overall impact of the health cluster is that healthcare systems can provide to citizens and patients equal access to innovative, sustainable, and high-quality healthcare, thanks to the development and uptake of people-centered solutions. So that's the main goal we are trying to achieve. And then, of course, how does this broad expected impact relate to healthcare procurement and the topics I'm going to present? Now, you can see this broken down in the specific expected impacts for Destination 4. So here we are already discussing context. I'm already presenting the topics in a way. So proposals should show how they will contribute to at least some of the impacts you see on your screen. They do continue to cover some legacy areas from Horizon 2020. So health promotion, disease prevention, patient empowerment, to name a few. But they also put a strong focus on the governance of our healthcare services and systems, introducing targets of effectiveness, of sustainability, of collaboration, and of course, as I said already, of resilience and preparedness vis-a-vis health threats. So why do we think that the procurement of innovation fits nicely in this framework? While procurement is not the only means to achieve these problems, it is an often neglected part of the solution. So something that we think of a bit too late for our systems or for our procurers to be able to buy the best solution they need, to achieve a reasonable price, and without taking too long to install it and be able to actually use it. This became all the more evident, in my view, with the COVID-19 pandemic, which highlighted issues such as the scale of the procurement, and the timing, and the financing, or the coordination of the procurement, be it at national level or cross-border, and be it ordinary procurement or emergency procurement. So COVID-19 also raised issues of supply chain diversity and security, and showed the potential benefits of digital solutions to patients, health professionals, and citizens. So this pandemic has demonstrated that new critical challenges for healthcare systems may arise in the future, which will need to be addressed properly, swiftly, and sometimes with innovative tools and flexible approaches. However, I have to say that we carried out recently a benchmark study in DG Connect on innovation procurement, which showed that in Europe, investments in innovation procurement are 2 times lower compared to, let's say, other leading global economies, with underinvestment being prevalent, particularly in R&D procurement and in the adoption of digital solutions. Which is, of course, a very important conclusion for us, because these are both areas that we take at heart. Furthermore, collaboration in Europe remains low due to factors such as diverging policy and legal frameworks, language barriers, fragmentation of our healthcare systems, different preferences of procurers and patients, or risk aversion, lack of capacity to take advantage of the opportunities here and there. As innovation procurement is crucial for modernizing the public sector and business growth, mainstreaming innovation procurement is of strategic importance to strengthen our competitiveness. By closing the gap between supply and demand in a way that reinforces our strategic autonomy, innovation procurement can also make a contribution to our economic recovery, which is another key target of the calls for healthcare. It can increase the resilience in the supply chain by opening up opportunities for European innovative companies, such as startups and SMEs in particular, to access the public procurement market, attract financial investment, and scale up their business. So you can see that addressing these challenges is part of the expected incomes that should be achieved by EU-funded actions under the Destination 4. And while I will not read them through, I think by now you have a good idea of what the underlying thinking is on what needs to be achieved. So coming to the 3 calls, the first one is the policy-related one, and it's the creation of a healthcare innovation procurement network. Here, I only would like to state for once that my presentation is trying to be as accurate as possible to the call text and faithful, but it is only the actual work program that you can go and have a look into to see the exact phrasing and the nuances of what we want to achieve. So please keep this in mind, especially if you intend to prepare a proposal. So we believe that the successful proposal for this topic would need to lead to outcomes which contribute to the impacts I just described in the previous slides. A proposal for the healthcare innovation procurement network topic would have to show its contribution to all the presented outcomes. But I think that it would be better, instead of reading the call text, to show you a visual illustration of what these outcomes should be and explain it. So what do we want to have? We want to have a network of procurers. And in order to do what? To achieve what? Well, first of all, we want them to have a common understanding of what are their needs and their priorities, and which ones are better dealt with by each procurer alone, and which ones are better dealt with through collaboration, and at what level. I think the interested procurers would have to think what type of innovation they need to procure and how they can work together in order to do that. Now, as a second step, these interested procurers would have to develop and define appropriate strategies to do that, taking into account, for example, the impact of COVID-19 on health service providers and healthcare policymakers, and what the maximum impact innovation procurement strategy would be now under the current circumstances. And then, of course, as soon as strategies can be defined and in place, how can procurers collectively increase their capacity and mainstream best practices in order to not only implement them, but also monitor them consistently and evaluate the execution of them, to create this sort of feedback loop. And finally, ideally, if a network of procurers reaches that level, then maybe they can scale up and increase their collaboration to maximize the outcome and the benefits both for them and for the communities they serve. So what are the needs for a large-scale collaboration there? Is it coordination, is it interoperability, standards, policy, what is it? So these are the outcomes that such a project to be funded would achieve. A network of procurers responsible for deploying health innovations in the EU, and making sure that internally they transfer knowledge and they build their collective capacity from more experienced one to less experienced one. Then also being extrovert, engaging with all the external stakeholders necessary. So health sector, research sector, industry, to have a holistic approach in innovation procurement. And of course, then ideally scaling up the collaboration in health, regardless of the instrument. This is not a topic to promote the PCP and the PPI instrument as the Commission thinks about it, but it could be about any other innovation procurement instrument which the procurers consider useful. What are the key elements to achieve the outcomes? Well, like I said, we kind of think this is necessary even at the proposal stage, but also in the project stage, that there is a needs assessment, a state-of-the-art analysis, and the usual things we have, like a literature review, taking into account other ongoing initiatives, relevant initiatives in the area, not duplicating work, but mainstreaming the interesting stuff that is around there in the new project. But mainly, the next important steps are the transfer of knowledge, a range of appropriate capacity building measures, in particular twinning activities, to transfer knowledge and experiences from the most experienced procurers to the least experienced procurers. For this, we foresee financial support to third parties, so grants to third parties of up to 60,000 euros per party. Then a mechanism for the decision makers, the health procurers, to facilitate the use of innovation procurement and to facilitate the coordination in tackling the challenges they face. The strategies, like I said, so an action plan which would be adaptable in a healthcare organization in Europe, irrespective of geography and type of procurer. And of course, mainstreaming collaboration by engaging all the relevant actors, which are necessary for doing innovation procurement successfully in health. Key activities in order to achieve that: an open market consultation with the industry to see the state of the art and how the industry and the patients respond to the challenges and needs identified by the procurers. The development of capacity and cooperation models, again, irrespective of innovation procurement instruments, the identification of barriers and proposing solutions at national or cross-border level. We have some examples there, but we want to hear from the procurers actually. And the potential future planning for procurements based on the identified common needs. Now, this is not a call for preparing proposals for future PCC or PPI goals in Horizon Europe. It's for potential tangible procurement plans of the procurers themselves, irrespective of instrument and funding source. And of course, taking some measures to ensure the sustainability of the network's existence as much as possible after the end of the project. So key requirements in summary: a critical mass of European procurers, so not only a couple, having experienced and less experienced ones, and also have a geographical balance. So no clusters of a particular type of procurers, so no north versus south divide or west versus east divides in the proposals, but quite an inclusive consortium. And the project led mainly by procurers, including also potentially health authorities or competence centers for procurement and other bodies which can support them in carrying out innovation procurement. but also a kind of a holistic participation from procurers themselves. So involving the key decision makers within the organizations and not having projects led by a single department of the procurer, like only the procurement department, ignoring the clinical needs of a health service providers, or the opposite, only a clinical department ignoring the procurement side. So we want to see that sort of ownership. In the technical details, which are interesting, always the deadline for applications for this particular call, which is the 21st of September. The budget, so 5 million maximum for typically for one project, but of course this is an indicative budget. It could be another amount, especially lower if you don't need all that money. And of course, the type of action, which is coordination and support action, which means that through this topic we don't fund procurement itself. That's the policy side of it, I would say. And I would like now to turn to our PCP and PPI call topics for 2022. So the logic of the expected impacts for destination 4 that I explained earlier remains the same, as you will see, but the focus being here in increasing the resilience of our healthcare systems in the context of the economic recovery. So what are these two topics? These are sister topics, means that to a large extent the objectives and the context is the same. So I won't go twice over that. What I would like to explain is that by launching a PCP and a PPI topic together, we aim to attract procurers which need a different maturity levels. So through the PCP topic, we would like to attract a consortium of procurers who want to address needs which are not yet there in the market, so they want to fund research at the levels of solution design, prototype development and testing in a real setting, to bring innovation closer to the market to address their own needs, and other potential consortia of procurers through the PPI, where their needs can be addressed by solutions which are already close to the market. They don't require research, but they require this sort of early customers, which will give them the opportunity to deploy in a real setting. These topics are, there's more time to apply for these topics, so the deadline is the 21st of April 2022. I think they will be open for applications as of October, but of course you can start preparing already. And the total budget is 25 million to be devoted for the PCP projects, each project 5 million size, and for the PPI projects, the total budget of 15 million. So more or less 5 projects and 3 projects respectively. Now, what we aim to achieve there through the pre-commercial procurement topic, for example, the outcomes is outcomes typical to the PCP projects in Horizon 2020, but it's worth stating it again. So we want public and or private procurers to develop innovation. And innovation can be anything, a product, a technology, or a change in systems and practices, and which are made in Europe. So there is a place of performance requirement, and can improve the preparedness and resilience of healthcare systems during our economic recovery. That is quite an important and main outcome. So of course, we also want the participating suppliers in these projects to be able to bring to the market their solutions. And in case these solutions are digital, we want them to comply with the relevant standards of security, interoperability, ethics, and privacy for citizens and patients. And of course, we want this process to help procurers give first customer references to the suppliers after the validation of the solutions, and also be able to exchange good practices and possibly create standards in a given area. What a successful proposal should include, more or less, a clear identification of the needs of the participating consortium, a well-developed work plan, especially in how the phases of the research in the PCP are going to be executed, and how the procurement is going to be executed, And in terms of content, a clear expectation on the health benefits that the solutions will ultimately provide at the end of the process, with a focus on the accessibility of the solutions and their affordability, the efficiency of deploying them in the local settings, and of course, a serious consideration of how the solutions would contribute to the health, to the resilience of the healthcare systems, because that's the main area of intervention here. Standards are good, digital and green transition contribution is good, and any measures to ensure the sustainability of any good practices developed through the life cycle of the project is also something to be desired. Now, I will not repeat the same for the PPI, because you will see that the aims and the outcomes are similar. I will again simply say that the PPI is about deployment. So there is a slightly different story. The solutions are mature. They don't require new research in the phase of the procurement, and it is more a story of deployment and testing in the real setting. So there again, we want more or less the same outcomes through a different process and a different maturity. And the scope is similar in this case as well. Now, a few novelties in Horizon Europe, which I think would be interesting for you. We have increased the funding rates both for PCPs and for PPIs. So it's now 100% for PCP projects and 50% for PPIs. And this covers both the procurement itself of the solutions, but also what we now call the related activities, which is all the other project management, communication, or standardization activities you might have through the project's life cycle. And through these projects, the procurement budget should be at least 50% of the action. In the past, this was 70%. So I think there is now the opportunity to have more funds for running your project if you face difficulties in the past in doing so. And finally, some practical details, which is further simplification in Horizon Europe. So shorter proposals, 30 pages maximum limit for a CSA, 45 pages for PCPs and PPIs, and the standard consortium composition requirements for the PCPs and the PPIs, which is a minimum of 2 public buyers from 2 different member states or associated countries, independent of each other, and at least one of those 2 should be a public buyer from a member state. They will have to sign a self-declaration at the time of the application, and then if a proposal is selected, they may have to provide proof that they are public procurers in the sense of a public procurer in the public procurement directives of the EU. So that is more or less it. What I would like to present now in 30 seconds is additional resources you might want to tap into if you're interested in submitting the proposal. And in this case, there is some essential readings. So the call text itself, but also the general annexes of the Horizon Europe work program and the other documents that you see listed there, especially the application form and the evaluation form, so that you understand what you have to think about when filling in a proposal and how it's going to be evaluated. Be mindful to check the right evaluation form and the right application form for the type of action. It's different from a CSA, for a PCP, or for a PPI. And finally, point you to a set of workshops we held in the previous 2 to 3 weeks to present these goals and to present in a holistic way how innovation procurement can help healthcare, from how to do a successful proposal to the topics that I just presented, and to bringing forward best practices of previous and ongoing projects we have. And these are the 4 events I think you can go to. And then that's it. Thank you very much, and happy to answer any questions if you have.
Thank you very much, Orestes. I would like also to ask Christina to join the questions part of this session. I only have one question for both of you, that is about the impact of all these financial programs that you have, both IT and also the European Commission, because as we could see, during both presentations from the IT and also from the European Commission. Well, we have so many financial instruments now. Also, I think also due to also the part of the European Commission due to the COVID-19 that they wanted to promote all these kind of financial instruments. So the question is that if you expect a higher impact on our community of researchers and innovators, thanks to all these financial instruments that you have now implemented, that new calls that they are going to be open soon. Yeah, maybe Cristina.
Yes, definitely. I think impact is now the driver of all the calls, and we need to measure it. And for example, just to give you one example, we have a specific area that is in high value care, so value-based healthcare, in which EIT Health is only funding the part of really coordination and collecting data for evaluation in order to make sure that we can really provide this evidence on the impact. So this was also previously mentioned by one of the speakers, that we need to provide proof of cost efficiency, but not only cost efficiency in economic terms, impact can also be this value for the citizen, better quality of life, many other aspects that we are very poorly measuring at the moment. And I think we need to dedicate resources also to ensure that we are creating this impact, because in the end, healthcare is not only about improving efficiencies in the healthcare system, yes, but it's about improving the quality of life of the citizens, and we need also to make sure that we can also measure that part. So yes, I think to your question, two things. I think aligning resources, I think will generate more impact. Second is the alignment also of private and public investments should also generate more impact. A third, we have this pending issue of being able to measure and assess it properly and also coordinate it.
Thank you, Cristina. Orestes?
Yes, thank you for the question. I think it was clear in the presentation, which actually reflects the program structure and aims, that now the focus is really indeed on impact, and the projects, well, before they even become project, they will have to make the link of, not that we are going to do something, but how this something is going to contribute to very specific impacts. And we are looking forward to really receiving proposals which will have a credible mechanisms for measuring and for assessing that, even if it can't be measured sometimes, analyze it qualitatively. So we do expect that this approach will improve the impact and will work towards the areas that I explained. But it's also important to note maybe that we also took measures of making the instruments friendlier, especially for the PPI instrument, by increasing the funding rates and allowing for more flexibility there for the projects. And we hope that this will help more good proposals arrive, and the consortia and our stakeholders to have more impactful projects. So that's, maybe we could call it measure 2. And then the third one is that you see we are launching a mix of institutional cooperation and funds for R&D and for deployment, in order to try to maximize that impact and not simply throw funds for deployment without any strategic orientation, or not try to have a lack of a community or a common understanding of how a thing works, and simply go for funding individual projects. So I believe these sort of 3 actions summarize a bit how we see impact being improved in the new programming period.
Thank you very much, Rose. I'm going to give the floor to Anna if there are any questions on the slide, and also to check the results of the poll of the conference.
Thank you so much, Jose. I have we have one question. It's as a public body and a public institution. What was the impact of COVID-19 in procurement in both organizations? Orestes? And Cristina.
Cristina, please go ahead.
This question is more for Orestes, but what I can tell you, the impact of COVID-19 in our partnership, and that includes a lot of public providers, healthcare providers, is definitely, I mean, it has affected in all the areas. But we launched last year a specific call on rapid response to COVID, and there was a significant participation, of course, of all the public services. And one of the leading projects that we had was led by Hospital Clinic in Barcelona, which was an AI instrument to really assess the prognosis of patients at the point of incoming in the hospital, to see, to identify early enough which patients could have really a bad prognosis and go directly to a specific path. And with that way, they were able to reduce mortality by 50% within really 1 month of use of these innovations. So what we've seen, for me, the main impact was that they could react much faster than normally in terms of not only designing research products, but really implementing them in practice. And even escalate to other geographies. So this concrete project was also further scaled to Rotterdam and to Louvain within months. So which is something that was never happened before in that sense. So I think what COVID brought is a different dimension in the size of the project, in the speed of reaction, and in the capacity of adoption by the public system.
Thank you. Orestes?
I won't say many different things. I think what Cristina said is the key message. So I will describe maybe a different story reaching that message. So for us, there are things which worked well and then quickly. A good story is the successful procurement by the Commission of the disinfection robots, which were deployed in several EU hospitals across the EU. And that is an example of how procurement can help quickly, especially in a coordinated way, address imminent healthcare challenges like that. Then, of course, there are what matters is depending on the case, the choice of instrument. So there were also other instruments we chose, which are not procurement instruments. We had 2 fast-track calls for COVID-related projects last year, which were not procurement per se, and in the end they used this instrument of financial support to third parties, so grants within grants, to help develop solutions like that. That's another approach which was handy at the time. When it comes to our traditional projects, innovation procurement projects, I would say, we noticed that our healthcare stakeholders were, of course, hit by the pandemic, and it created more difficulties to implement them. So there we had delays and problems, which are, of course, understandable. So sometimes this vehicle might face some challenges in emergency situations, and that's what we want our partners to reflect in calls such as the Innovation Procurement Network, how to make these instruments as well more flexible in such cases. But we also saw some interesting results, like in projects which were not very posh before the pandemic, but then by developing patient monitoring solutions, for example, became fashionable and deploying them in the hospitals. So that was an interesting development to see there. So in the end, I would say that and after a lot of consultation with the stakeholders on how to do procurement better, the choice of instrument is important. Not every instrument is right for every particular case and time. The readiness level and especially the administrative burden involved in the process is an important thing to consider, and the collaboration, which is an element for the size, as Cristina said, that our stakeholders want. They want bigger projects. The idea is how to make them more efficiently.
Thank you so much, Orestes and Cristina. I kindly invite our speakers of this day for the polling session, and also Yanni, if you have any question, don't hesitate to to ask them. So we will show you what is what are the results of the polling session. So most of the audience, or the 50% of the audience, answer the question of, in your view, which will be the most relevant benefits of innovation in personalized medicine, and the 53% of the audience just answer higher quality healthcare services for patients. So what do you think, as experts in this area, what do you think of the answers? What are the most relevant benefits of innovation? Orestes, Gianni, or who want to answer, it is welcome. Thank you.
Well, I mean, this is Gianni. I think it's, it also gives us an idea of what patient wants from personalized medicine. So it has to become, it has to be brought into healthcare services. It has to become actual services for patient, and that's the most relevant thing we need to be aware of, that all the investment that we are doing on all the features of personalized medicine at the end have to be back to the patient. So I think this answer reflects, I mean, all the four answers are true. Let's say, like, there are like expected benefits from personalized medicine, but it gives, this answer stresses the importance of personalized medicine for the patients and the citizen, I would add, because it's to them that all these efforts and investment have to be brought.
Thank you. And the next one, do you agree that research and innovation in personalized medicine and health in Europe should be a priority in your region? I think it's the obvious
That's
answer.
comforting.
Yes, of course. And the last one, how can regional institutions best support the development of prevention programs for personalized medicine? It's most of them, I think the two answers, the first two answers are equal. So provide adequate training and formation for medical personnel, as well as create and further develop agencies that focus on supporting screening and prevention programs related to personalized medicine. So what do you think, as speakers of this conference and the coordinator, of the answer of this question? Thank you.
If it's for me, I mean, like, again, I agree with all the answers that have been chosen. I agree that also, like, the training for medical personnel is important is a feature that we have also faced in the past of our project. Access and availability to data is, I think it's important, despite the lower percentage. I think, as was pointed out also today, it's the key for enabling personalized medicine. So I agree with all the answers again.
Yeah. So we learned in COVID-19 as well. So lessons learned. Thank you so much. And I will give the floor to Jose.
Thank you very much. Thank you very much, Anna. Well, just the closing remarks of the first session, the first journey of the conference. Well, connected to the topic that Orestes had today, tomorrow it will have a mathematics session about public procurement of innovation process, and also some initiatives that we have here in Sergas and in other regions in Europe related to personalized medicine and PPI. So I would like to give the floor to close the day to Gianni De Rico as the coordinator of the Regions for Permit project. Gianni, just a few words and
Yes. So I mean, like, I mean, all the speakers have said it all. I mean, they've pointed out all the main challenges. We have heard some very good practice from Gemelli that really needs to be disseminated and yeah, all over Europe. So in the first part, we have heard some big challenges. And the second part, we have also learned how the, let's say, which are the financial instruments that can be brought, and especially when we come to the public procurement, the CSA call for proposal that that was presented by the policy officer of the European Commission is really important, and it could be. I was really thinking that what Dr. Kalyantzidis said could actually be an outcome of this pillar, like try to understand, try to bring personalized medicine as a priority also for public procurement, also leveraging the excellent work that Galicia and IHS have been doing. So I think I would like to thank all the speakers for the very comprehensive and complementary points of view that they have provided. And of course, a big thank for this first day also to you, Jose and Ana, for organizing this first session in a very brilliant way. And I'm really looking forward for tomorrow's discussion.
Well, just to invite you tomorrow for the next part of the conference, that, as I mentioned, it will be monothematic about public procurement of innovation. And thank you, Anna, and see you tomorrow at 10 in the conference.